Jayanti ma'am, good evening.
Good evening, Dr. Kanik.
Ma'am, we'll start in a minute, ma'am.
Yeah. What is the format like?
Ma'am, it is an hour-long case. We have two cases. The first case I have kept is portal hypertension with the case of splenomegaly. The second one is the carcinoma gallbladder. Usually, the candidate runs through the history without stopping. At the end, they sum the history. So we revisit slide by slide and ask questions or give comments or whatever. If they missed out on something, you can address. Same thing, clinical part, they run through until the end, they arrive at a summary of the clinical findings. Then they give a working diagnosis. This gets over in half an hour time, ma'am. Then we have full half an hour on evaluation, medical management, surgical management, endotherapy, and if there are any newer advances, candidate should know. This is a teaching format, ma'am. So basically, if the candidate finds or not is able to answer to your expectation, I request the faculty to kindly give the answers what they expect, ma'am. So that is the way we have the case
This
discussion
is
going on.
2 hour session, no? 2 hours.
Yes, ma'am. Yes, ma'am. Each case 1 hour, ma'am. So, Professor Kirit Palmer, warm welcome. Friends, without much ado, it's 8 o'clock.
Thanks, sir. Good evening.
Good evening. So, this is our weekly Friday clinical session. Today, this is the 336th session, and this is the 617th and 18th case we are discussing today. Today is an exclusive hepatobiliary program, and we have a very eminent faculty who has joined us. And off the lead will be very senior most our teacher, Professor Jayanti ma'am. She has served as the head of the department at multiple places. Brilliant student from Christian Medical College, Vellore, and right now she is faculty at the Global Hospitals at Chennai. We have Professor Johnson Maria Anthony, head of the Department of the Surgical Gastroenterology from Government Medical College, Salem. Professor Amit Gupta, again head of the HPB section of the General Surgery Department under the General Surgery. He is from All India Institute of Medical Sciences, Rishikesh. Again, Professor R. Kalayarasan is an eminent surgical gastroenterologist and robotic surgeon from JIPMER. Right now, he is part of the academical unit of the Apollo Hospitals at Chennai. We have Professor Venkatraman Reddy, again HOD from Sri Venkateswara Institute of Medical Sciences, Tirupati, who will be joining us shortly. Professor Bharat Nara should be joining us shortly. I also take this opportunity to thank Professor Seema Khanna ma'am, head of the unit at IMS BHU Varanasi, and Professor Amit Gupta for kindly permitting their students to present a case here. We also thank the respective HODs, Professor Satyanam K. Bhartiya from IMS BHU Varanasi and Professor Som Prakash Basu from AIMS Rishikesh for permitting their students to be part of it. And we have our own eminent faculty joining us, Professor Kirit Parmar, Professor T. Srinivasan, and I expect the others to join us shortly. So without much ado, we'll have the first presentation. Can we have the Dr. Muskan Dugar? She is a postgraduate resident from IMS BHU Varanasi to introduce herself, her unit faculty and HOD and start your presentation. Good luck to you, doctor. I request all the others in the group to be in silent mode except for the student and the faculty. Should you wish to ask questions, please use the chat box. Welcome, Dr. Bharat Nara. Bharat is from Apollo, Hyderabad. She heads the hepatobiliary and transplant unit from Apollo, Hyderabad.
Thank you, sir.
Muskan, the stage is yours. Faculty, please take over. Make it full screen, Muskan.
Good evening, everyone.
Good luck to you. You're perfect, ma. Good luck.
Good evening, everyone. I am Dr. Muskan Bagar, JR3 General Surgery from the, IMS PHU, and I'm presenting a clinical case under the moderation of Professor Seema Khanna ma'am under the Department of General Surgery, IMS PHU. I'm presenting a case of a 32-year-old female homemaker, resident of Jaunpur, Uttar Pradesh, presented to surgery OPD with lump in left upper abdomen for 20 years and a single episode of hematemesis 20 days back. Lump in the left upper abdomen was for 20 years, which was insidious in onset, gradually progressed to the correct size. Lump was initially confined to the left upper quadrant and has progressively increased in size to extend up to the umbilical region. It was associated with abdominal discomfort intermittently. She also has a complaint of single episode of hematemesis 20 days back. It was scanty in amount, coffee ground vomitous, non-projectile, not mixed with food particles, not associated with pain or nausea, relieved with oral medication from a local hospital. There was a similar episode 20 years ago, which was relieved after she was admitted in a local hospital and took oral medications for 4 to 5 years. No documentation of this admission was available. There is no history of fever, chills or diarrhea, abdominal pain, abdominal distension or abdominal trauma, melena or bleeding per rectum, altered sensorium, yellowish discoloration of eyes and urine, pruritus, hematuria or dysuria, and early satiety or weight loss. History of hospitalization for similar complaint 20 years back was started on oral medication, which continued for 4 to 5 years, then stopped abruptly with no documentation. She also has a past history of 1 unit of blood transfusion, which was done 20 years ago. No documentation of the same is available with us. There is no history of any surgical intervention in the past, and there is no history of any known comorbidities. There is no similar history in other family members, and her menstrual cycle is of 28 days, which is regular, and her last menstrual period was on 4th of May. She is a para 2 para 2, and both of their children were born by normal vaginal delivery, and the younger child is of 12 years of age. She takes a mixed diet with a normal bowel and bladder habit. She has a normal sleep pattern and has no history of alcohol intake or substance abuse. There is no known allergies and no birth history is available with us. Summarizing my case, a 32-year-old female with complaint of gradually progressive painless lump in the left upper abdomen for 20 years associated with single episode of hematemesis 20 days back with a history of similar episode 20 years ago and 1 unit of blood transfusion 20 years back. So should
I'll just ask here. So apparently the patient has been unwell since the age of 12, right?
Yes, sir. Yes, ma'am.
Yeah, so so the history is at the age of 12, she's noticed some lump or mass, whatever she's had, and she's had a bleed then, right? So
Yes,
I just want to know, so what is the educational status like?
Ma'am, I have not formally tested the educational status or the economic, socio-economic status of the patient, but she belonged to a rural area.
No, she's been investigated or she's not been investigated at all from 12 years of age?
No, sir. No, ma'am. She has not been investigated at all. She came to us as a index case. She was taking some medication from the local.
Even during pregnancy, she was not investigated, is it?
No, ma'am.
It's not possible, no? So I think somewhere there's a missing link in the history because someone would have picked up the spleen, which is about almost touching the umbilicus, right? So it's not possible that the obstetrician and gynecologist whoever seen the patient at that time during the first pregnancy would have told her that she has a liver problem and would require an evaluation. So this thing is, otherwise she becomes, and it's not a single episode. There are 2 episodes of bleed. You'll have to describe the bleed to a larger extent to know how severe was the bleed. Was it related to NSA? Was it a peptic ulcer bleed? Is it a varicose bleed? How would you know that from the history? Can you differentiate? I say that she's got a spleen which is incidental, but the bleed is not of splenic origin.
Ma'am, peptic ulcer bleeds are generally associated with pain and food intake. And another point of discrimination is the recent bleeds are if it can also lead to massive
No,
bleeds,
no,
but
that is
peptic ulcer
theory.
bleeds
What
are
I'm
generally.
asking is, what was it in this patient? I just want to know in this patient, what was the severity of bleed? Was it just
Ma'am,
a mild bleed, or was it massive bleed? Was it
ma'am, it was a mild.
spontaneous? Was it
Ma'am,
provocative?
ma'am, it was a mild bleed, and
So it
according
is,
to the
so it's not related to portal hypertension. Okay, it's just a mild bleed, right?
Dr.
So
Muskan,
so
when the
you have to be very clear about this, no? Because this is a patient that they, now we need to know that bleed, whatever is the parents or if there's another person to give you a comment on the patient at the age of 12, it's fine. If not, then we say that we have no further information as far as that is concerned. And you have to tell what was the educational status. That is, what's the scholastic history? Has she been doing regular in her classes? Are we dealing? It is obviously a spleen. So are we dealing with a myeloid? Is it more of a hematological issue we are dealing with? Or are we dealing with a liver-related issue? So all these things should come out from the history. And it's not possible that at least during the time of pregnancy, even if she remained, it's not possible, no? Like, I mean, huge lump right up to umbilicus, going through a normal pregnancy, 2 pregnancies, normal delivery. It's just impossible that the doctor attending her would not have told her that she has a problem. This is my comment. Okay. Others can take over.
Was she suffering from any bleeding disorders in the young age?
No, sir. According to the history, sir, she did not give any history of.
You have written documentation not available, but you could have
Yes, sir.
elicited the history, isn't it? From the relatives, parents. See, from 12 years, probably she wouldn't have known. But that's what madam is asking. You could have elicited the history from the parents.
So she
No,
then she
nothing
was.
wrong in it, which you forgot to think we are telling, because you are
Okay.
dealing with something with bleeding, an hematological disorder, probably. We do not know what it is. So from 12 from 20 years, she has been bleeding. So from 12 years, so young age, has she got any hematopoietic disorders, any bleeding diathesis? You forgot to ask.
Yes.
Okay, right. You can go to
Yeah,
the previous
Muskan,
slide.
can this
Sir, please,
patient
sir,
come to
please.
you?
Sir, please, sir.
Yeah, Muskan, can this patient come to you with a history of multiple blood transfusions? Is it feasible?
Sir, it is feasible. She can come with multiple blood transfusions.
So the point has been raised very pertinently by Dr. Jayanti. She's asking a very valid question, right? When the spleen is so much enlarged that it is going up to the umbilicus, then how come she completed 2 pregnancies, that too without much investigations? Right? Because no gynecologist or obstetrician will miss this important finding, right?
Yes. Yes.
And she must have been worked up, proper thorough worked up, peripheral smear, etc., and complete CBC, etc., during the pregnancy itself, during the antenatal visits, which might have picked up some or the other cause, right?
See, you asked the history of abdominal pain. Why you asked the history of abdominal pain?
Sir, in case there is any due to if I'm suspecting a spleen, then it can be due to any if there is a sudden enlargement in the spleen, it can go into infarction, which can again lead to pain abdomen. And hematemesis, if I'm suspecting, we can also say it's a peptic ulcer disease, which also presents with pain abdomen.
So you want to say that because of peptic ulcer, patient might be having pain with this much huge spleen.
No, sir, but ma, if the so by the basis of history, sir, I cannot exactly say
You
that.
cannot make out, right?
This patient has got a massive spleen. Supposing this patient had pain, what do you think could be the causes of pain in a patient with a massive splenomegaly related to the spleen?
Ma'am, patient can have perisplenitis due to infarction, or there can be any abscess formation in the spleen, and it can be because of
What are the other possibilities? Can it be portal vein thrombosis?
Yes.
Madam, she has not examined the patient, madam. We have not come to the examination.
No.
Yeah, yes.
But I just
The
asked
We are
you
just
pain.
Yeah.
Pain in a patient with a large spleen. One of you had asked a question. What are the cause of pain? So it's not an ulcer disease pain. Related to the spleen, what are the possibilities? Unrelated to the spleen, what are the possibilities? Because the bleed is very mild according to you. Bleed is very mild. This present bleed is almost trivial bleed, no? How do you assess the bleed? How do you assess the intensity of the bleed in a given patient? Mild, moderate, massive? Any scoring system?
Massive bleed is said when the patient has lost approximately 1.5 liter of
No,
blood, or there is a
what we want to know is just a clinical, no? So only clinics. So what will be the clinical presentation for massive bleed versus mild bleed versus moderate? So mild bleed is a person, bleed is a person who just comes walking to the OP and gets evaluated and just goes back. Okay. This is the simple clinical history taking. A massive bleed will present with shock. And the moderate person will be the person who will have giddiness, syncopal attacks, and blackouts. So certain things you can almost pick out by saying this, whether this patient could be having a mild, moderate. So based on this, what do you think this patient has a mild bleed?
The patient has mild bleed, ma'am, because she walked.
Okay, then you
she
take
came
up in
into
a
the
summary and discuss what are the possibilities, okay, if it's mild bleed. So what are the possible causes? What questions would you ask? Lead questions to know if it's a mild bleed. What are the common causes of upper GI bleed?
Ma'am, common causes of upper GI bleed are peptic ulcer disease, it is the gastritis. It can be varicose bleeding. It can also be Mallory tears.
So from the history, so we're asking in this particular, from the history that you have, what are the questions that you'll ask to say, okay, it is acid peptic, or is it erosive? Is it Mallory Weiss? What lead questions will give you a clue?
Ma'am, we will ask for the history of NSAIDs intake.
So was there any history of NSAID? Was there any history of NSAID in this patient?
Ma'am, she took oral medications for 4 to 5 years, which was not documented. So I cannot confirmly say that there was no history.
I'm asking for the present episode. This history you took now, no? Or is it?
Yes, sir.
I just want to. You said
currently she is not. No, ma'am. In the recent history, there is no history of any incident.
Okay, I'm not getting the history right. Others can take over, please. Until I'm not getting the history right. History will give a clue to the diagnosis. That's what I wanted to say.
Yeah, Muskan, when she took regular medication for 4 to 5 years, at what age?
So at the age of 12 years of age, when she had a first year history of hematosis.
So at that age, whatever has happened. So at that age, whatever the chronology of the events, probably patient may not be in a condition to tell you exactly the details, right?
Yes.
So then there are certain missing links in the history, right? Because continuously for 4 to 5 years, what sort of treatment patient was on? Was she on some iron replacement therapy? Was she on some other drugs that you cannot comment upon?
Yes, sir.
Right?
Yes, sir.
You asked the history of abdominal trauma. Why you asked the history of trauma?
Okay, I think.
Yes,
abdominal trauma can. So abdominal trauma can lead to any either thrombosis in the portal vein or the splenic vein. So it can lead to splenomegaly.
So this much huge spleen with trauma, what do you feel? How the patients can
The patient will there is a huge spleen. It will with trauma, so it will not present with a long history, and patient will have the patient will have any symptoms of hemodynamic instability.
Yes. So the spleen can be easily ruptured, these kind of spleens. So that's why it's easily, patient can be in hypertension, splenic rupture, anything can happen, right?
Please summarize. and give your diagnosis and differentials.
Ma'am, should I move to examination?
No, summarize the case and give your differentials. No, you'll have to give your differentials with the history. No, I do not
Ma'am,
know what's
history,
your pattern because I mean, that's the way we need to know what's the clinical working diagnosis before you go to examination. So,
ma'am,
what's your
since
working
it is a long,
diagnosis? What's your working diagnosis?
ma'am, since it is a
No
left
more, no
lump
more
in
history
left upper,
taking. No more history. Just tell what is your differentials in this patient. That's all. We're just asking you what's your diagnosis or differentials. That's all. After history taking. No more
ma'am, this lump
discussion
could
on
be,
age of onset. Sorry?
ma'am, this lump could be arising from stomach.
No, doctor.
Spleen.
See, I would just say I'm dealing with a case of splenomegaly with 2 episodes of bleed, right? If you have any other differentials for the mass, then you give a differentials for the mass. So what are your differentials at this stage? And then you go to examination.
Why you want to say
Ma'am,
stomach?
No,
sir, I will rule out stomach because there is no, because there is a long history, so I cannot rule in stomach pathology in
what
this
stomach
case.
pathology would present for 14 years, 20 years?
Ma'am, I
No,
have
would you
ruled out, ma'am.
consider that? Would you consider that at all in your differentials in
No,
this
ma'am.
patient?
No, ma'am, I will not consider it as a differential. I will just move with a working diagnosis of splenomegaly, ma'am, in this patient.
Only splenomegaly?
Yes, ma'am.
What about the bleed? We'll ignore the bleed. You mentioned two bleeds and long-term treatment for 5 years. So should we ignore the bleed?
No, ma'am. Splenomegaly can lead to bleeds, total hypertension.
Okay, you proceed to your examination because, I mean, for us, it's a different way of approach to the case. You must get a history.
Actually, it is vice versa. You are saying splenomegaly leading to portal hypertension. Is it so, or is it portal
No,
hypertension
sir.
leading to
Total
splenomegaly? What is the
hypertension
true
is
statement?
leading to splenomegaly, sir. Total hypertension is leading to splenomegaly and hematosis.
See, there are actually no coherence in your history presentation. So there is no clear-cut diagnosis, right? After summarizing the history. Move on to the examination, please.
So on general examination, patient is examined in a well-lit room with proper informed consent. She is conscious and cooperative, oriented to time, place, and person. She is afebrile to touch and pulse rate is 80 beats per minute regular. PP was 114/74 millimeters of mercury in right arm. Respiratory rate was 16 per minute, abdominal thoracic, and pallor was present. There is no icterus, clubbing, cyanosis, generalized lymphadenopathy, pedal edema. There is no stigmata of chronic liver disease observed. She weighed 56 kilograms with height of 148 centimeters and a BMI was 25.
Okay, just stop here.
On
Why do you look for
examination,
clubbing? Can you just stop here? Why do you look for clubbing, cyanosis, and generalized lymphadenopathy in this patient? How much time did you spend looking for this? Generalized lymphadenopathy, clubbing, cyanosis, and all. Why did you look for all this in this particular patient?
ma'am, because in case of any cirrhotic liver disease, it can the patient can have clubbing, and
Type of
in
liver
case of
disease? When do you get clubbing?
ma'am, if the
And
patient
you get
lands up in a
cyanosis? What are the cause of cyanosis and clubbing? In a patient with splenomegaly.
ma'am, if the patient develops hepatopulmonary syndrome or portopulmonary pressure is increased.
So what would have been the clinical presentation?
Ma'am, in case of
Why I'm
hepatopulmonary
asking this is, I am asking generalized lymphadenopathy. Basically, let it not be like a poetry, no cyanosis, no clubbing, no lymphadenopathy. This is what we say for all our patients, right? But when you mention this, just think twice when we're speaking on this. Why are we discussing at all about this? All right, that's my thing. What else would you look for in general examination in a patient with splenomegaly? It's a large mass, we presume it's spleen. After examination, you've said it's spleen. Then will you go back to look for anything in physical examination? In a patient with acid, what are the hematological conditions where you look for some findings in general examination?
Ma'am, we will look for pallor. We will look for icterus. Ma'am, we can look for any chymotic or purpuric patches. Ma'am, then we can look for stigmata of chronic liver diseases.
Sorry, I can't hear you. Audio is not good. I'm not able to hear you properly. What did you say towards the end?
Ma'am, we will look for pallor. Ma'am, we will look for icterus, and we will look for any ecchymotic or purpuric patches on the skin and stigmata of chronic liver disease.
Why do you look for ecchymotic patches, in this patient without a history? Someone is lying down. I think please switch off the video, okay? Because it doesn't look nice. All consultants sitting here upright and taking the people listening are all sleeping and lying down. Dr. Kanakavel, can you switch off the video for all the others, please? Yeah, please tell.
Because,
Will
ma'am,
you look
because
for, will you look for sternal tenderness? Will you look for
Yes,
sternal
ma'am.
tenderness?
Yes, ma'am.
I say it's a case of myelofibrosis.
Yes, ma'am.
What else will you look for? What are the other conditions that you look for?
And then we'll look for gout.
Okay, please
Gout
ensure that, because in a case like this, if it's a bedside clinic, it's a short case bedside and they ask you to examine and you say it's a large spleen, you should know what are the things you look for in general physical examination. Okay, that's why we're focusing on that. Okay, continue.
And then per abdomen examination, abdomen is flabby with umbilicus centrally placed and inverted. There is a visible fullness in the left hypochondrium and left lumbar region moving downwards with inspiration. Fullness becomes less appreciable on head raising. All corresponding quadrants move proportionately with respiration. There is no engorged vein, visible peristalsis or scar seen, and external genitalia are normal. Bilateral renal angles are free. Moving to the palpation, abdomen is soft, non-tender. Spleen is palpable 12 centimeters in size below the left costal margin in its long axis, occupying left hypochondrium, extending towards the umbilical region, not crossing the midline. It is smooth in surface, firm in consistency, with regular margins, notches felt over the anterior border. Upper margin is not palpable. Fingers could not be insinuated under the left subcostal region, neither ballotable nor bimanually palpable. No other organomegaly or lump noted. All hernial sites are intact. Bilateral angles are not ended and spine is within normal limit. On percussion, there is dull note on percussion over the spleen. Liver span is 12 centimeters and there is no evidence of intra-abdominal free fluid. On auscultation, there is normal bowel sounds heard and there is no bruit or hum heard over the lump or elsewhere. On digital rectal examination, perianal skin was normal anal tone with fecal stain was present and there is no blood on gloved finger, no mass or abdominally felt. On proctoscopy examination, there is normal rectal mucosa with no evidence of hemorrhoids or growth. On systemic examination, central nervous system was higher mental functions were intact, and in the cardiovascular system, S1 and S2 were normal with no added shunt. Respiratory system, bilateral equal air entry was present with no added sounds. Summarizing my case, a 32-year-old female with complaint of gradually progressive painless lump in left upper abdomen for 20 years, associated with single episode of hematemesis 20 days back, with history of similar episode 20 years ago, and 1 unit of blood transfusion 20 years back. On examination, spleen palpable 12 centimeters below the left costal margin, along its long axis extending towards the umbilicus, with no evidence of hepatomegaly, ascites, and stigmata of chronic liver disease. Pallor was present.
So, Muskan, what is your diagnosis now?
So my provisional diagnosis is splenomegaly due to portal hypertension. For the reason of portal hypertension, I would like to give my provisional diagnosis as extrahepatic portal venous
But
obstruction.
in your
or non-cirrhotic.
history and in your examination finding, what are the points which are favoring portal hypertension diagnosis?
So in the history, first of all, it is a long period of history. So and second is the hematemesis, sir, which again favors the diagnosis of portal hypertension and splenomegaly in case of splenomegaly. And during the examination, there was no
Do
any
you
signs
think
of
that such a lasting, portal hypertension patient will have only 2 episodes of hematemesis, that too mild hematemesis?
no, sir. In case of portal hypertension, tension generally patient presents with massive upper GI bleeding.
Any other thing in the examination which favors portal hypertension?
Sir, in examination, sir,
So why it cannot be just some she may be a case of sickle cell anemia, she may be a case of thalassemia,
yes,
she may be
sir,
a case of spherocytosis, right?
yes. So there was
So
no
why you
history of
want to
blood.
bring in portal hypertension here?
There was no history of any repeated blood transfusion, and also there was no this complaint of any jaundice, yellowish discoloration of sclera. And that's why I've put a provisional diagnosis of splenomegaly with portal hypertension rather than a hereditary
So
anemia. Sir.
do you see jaundice in all the patients of portal hypertension?
No, sir. So but in hemolytic anemia, so there is generally jaundice due to hemolysis.
What are the causes of massive splenomegaly?
And causes of massive splenomegaly is one is extrahepatic portal venous obstruction.
Extrahepatic never causes massive. Extrahepatic never causes massive. Massive splenomegaly is very specific for one particular type of portal hypertension, that is NCPF. Otherwise, they're all moderate. You'll never get a massive spleen coming up to the umbilicus in a patient with EHPVO. Give us the differentials for a massive splenomegaly. Give us, just classify and give a differentials for the massive splenomegaly. That's your diagnosis.
Now, massive splenomegaly can be due to infective pathology, like in case of tropical splenomegaly, and it can be due to Kala Azar, and in case it can be due to in case of portal hypertension, it can be due to
Classify.
non-cirrhotic.
Can you classify? Can you please classify causes of massive splenomegaly? How do you classify?
From the neoplastic
Name the infective
infiltrative.
causes. Tell what are the infective causes.
Now, infective, we have tropical splenomegaly syndrome and Kala Azar. In infiltrative, we have chronic myeloid leukemia, CML. And in case of congestive splenomegaly, we have non-cirrhotic.
What are the hematological causes? List out all the hematological causes of massive spleen.
Ma'am, it can be due to chronic myeloid leukemia. It can be due to sickle cell. Sorry. It can be due to hereditary spherocytosis, and it can be due to primary myelofibrosis, and it can be due to thalassemia.
Which one? Sorry, last one.
Thalassemia, ma'am. Thalassemia.
Thalassemia, massive spleen. Massive spleen and thalassemia at this age.
Thalassemia intermediate.
What are the infiltrative causes?
Infiltrative causes is primary Gaucher's disease and
there are amyloidosis, lymphomas. You must classify it. You must have infection, inflammation, neoplastic, miscellaneous, storage disorders. You must have a complete list. In this condition, just see whether any of them, your bleed history is where it's misleading us. If you had taken a good history of the bleed, you would have come to the right diagnosis. Understand? In EHPVO, you'll not get such a massive spleen. When you suspect NCPF, you mentioned second as NCPF. What will be the features of NCPF?
Ma'am, NCPF
What's the age of, can you just differentiate EHPVO and NCPF? Just differentiate the two in a given patient. Differentiate EHPVO and NCPF.
Presentation, age of presentation of EHPVO is a younger age in the second decade of life, and whereas non-cirrhotic portal fibrosis is of older, it's third to fourth decade of life. And
what age? What's the age of presentation of NCPF?
Third or fourth
What's the
decade
age
of
of
life?
Presentation? Sorry?
Third or
Which
fourth
decade?
Of life.
Fourth and fifth decade. So just 20 to 40 years. Then what are the other differences between the two?
Ma'am, in case of extravenous portal hypertension, there is spleen is not massive. Massive spleen, there is moderate splenomegaly, whereas in the NCPF there is massive splenomegaly, and it can the problem is in the second order of portal vein in case of NCPF, while in the extrahepatic portal venous obstruction, it is in the first order portal vein. And
First
ma'am,
order,
in
first
EHPV,
order will
there is
be EHPV is pre-hepatic, no?
pre-hepatic,
Will
yes,
be
ma'am.
pre-hepatic, huh? What else?
Ma'am, and NCPF can present with jaundice in the later stages and not in this EHPV.
Can they both present as portal biliopathy?
No, ma'am, portal biliopathy will be present in EHPV, ma'am.
Can present in both, madam, can present in both. Both are similar. So you can get portal cavernomatous biliopathy in both on PCC. And then what are the other what will be the HVPG in both these? To take a pressure gradient, what will be the difference between the two?
Ma'am, in
EHPG
case
and
of
NCPF.
ma'am, in case of ESPVO, pressure gradient will be normal, and in case of non-steroidal portal hypertension, ma'am, hepatic venous portal gradient will be raised.
What will be the value? Tell us a value, no? Cannot just say high,
So,
low.
ma'am, value, yes, ma'am. Ma'am, it will be
So,
below
so in other
5 mm
words,
of
1 minute, we'll just summarize it here. So in other words, just see that you have a good differentials for all the for all the massive splenomegaly, because this can come as a bedside clinic. Okay, and also have a differential between EHPV and NCPF. The whole problem with the presentation was that the GI bleed will always usually be massive. You'll never get a trivial bleed. If you have a trivial bleed, it's just not related to that. You understand? And if the person who's given her treatment for 8 years would have told her what is the primary problem, at least the doctor would have told her something that, yes, you have to take this for next 5 to 7 years. So your history is very, very, very important. Without the history, it's very difficult to make any clinical diagnosis in this patient. These are my comments. You can take over, sir.
Very rightly said by Dr. Jayanti. Muskan, actually, so many pertinent things you have missed. Anyway, uh, uh, do you think that a patient who is having portal hypertension, with whatever the reason is, for last 20 years, will not have ascites, etc., and spleen is enlarged to this point? Can this really happen? Do you see such kind of clinical presentation very commonly?
So in case of pre-sinusoidal, so we can ask the presentation.
So there will not be any free fluid in the abdomen then?
So,
Okay. So when you say that patient is having portal hypertension,
so on the basis of hepatic venous portal gradient, so when it is more than 5 millimeters of mercury, we can say it as a portal hypertension. And for clinically significant, it should be more than 10 mm of Hg, and for to lead it to bleeding, it should be more than 12 mm of Hg.
so how do you measure portal pressure?
So by cannulating the femoral vein, we place a balloon catheter in the hepatic vein, and on inflating the balloon, we take the wedge pressure, hepatic wedge pressure, and deflating the balloon, we take the free hepatic venous pressure, and on subtracting both the pressure, we get the portal vein, hepatic portal venous pressure.
Okay, now you have this differential diagnosis in your mind. How will you investigate this lady?
So I would like to move forward to confirming my diagnosis by ultrasonography of whole abdomen along with the color Doppler of hepatoportal system.
So what can be the finding in Doppler study?
What will be your
In,
level 1
established-
investigation in this patient? What will be the level 1 investigation in this patient? Level 1.
Level one.
What will be your first level 1? What will be your
Ma'am.
level 1 investigation? We'll have to do a complete blood count in the pectoral smear, no?
Yes, ma'am.
We don't know what we're dealing with. So you need that. Okay, ultrasound will be the diagnostic with Doppler. But what will be the role of CBC with the peripheral smear in this patient? What
Ma'am,
do you
it
expect
can,
in this patient? What do
ma'am,
you
it can
expect?
show. Ma'am, we expect either it can be due. It can lead to a hypersplenism picture, or it can be normal if considering a diagnosis of portal hypertension.
I do not know what's
Or-
hypersplenism. I do not know what's hypersplenism.
Hypersplenism will show bicyto more than radius reduction in more than 2 cell lines, either bicytopenia or pancytopenia. It will present as a splenomegaly, and the symptoms will be relieved after the removal of spleen, and the bone marrow will be normal cellular or hypercellular.
I'm asking you, what will be the counts in this patient? Can it be that the patient has got 4.5 lakhs of platelet count?
Yes, ma'am.
So what is it? All the time you're concentrating only on portal hypertension. But why can't you have can it be a myelofibrosis with pancytopenia? Can it be MPN? Can it be myeloproliferative neoplasm with JAK2 mutation?
Ma'am, neoplasm, I will not keep it likely because for 20 years you will not have survived.
We do not know. No, we have no idea what we are dealing with. We have no idea what we are dealing with. Can it be a storage disorder?
Yes, ma'am, but it will present ma'am early age, so I have not kept in the bit.
What will be the role of liver function test in this patient?
Ma'am, it will show the condition of it is a sinusoidal, the cause is sinusoidal, pre-sinusoidal or sinusoidal. If the liver is involved or not.
What do you expect the LFT to be in this patient? You expect the liver function,
It can be,
biochemistry?
if I'm suspecting a case of hereditary anemias, then it can show raised unconjugated bilirubin.
Doctor, are you suspecting that so your complete blood count will give you all that information, no, before you proceed for all this?
Yes.
In a portal hypertension, what do you expect? You had two differentials, EHP and NCPF. What do you expect the LFT to be?
May expect LF to be normal, ma'am.
In both?
Yes, ma'am, in both.
How is it normal that your non-cirrhotic portal fibrosis is very sinusoidal? So what are the possibilities? 20% of them can progress to cirrhosis. We have no idea, no? The liver span is just normal. So you can still have some changes in the liver function test. So we used to do what's called as bromsulfaline retention test in our days. And that totally told us that in NCPF, which is perisinusoidal, whereas in EHPV, it's pre-sinusoidal. Because it's perisinusoidal, 20% of patients can progress to cirrhosis. So a liver function test, supposing alphos and gamma GT was elevated on biochemistry, liver biochemistry, what is your take?
I will check ductal pathology as well, like portal radiopathy.
Yeah, so therefore, this is what we're asking. So you can expect, no, supposing you have raised alphos and gamma GT, then you have to suspect PCC in this patient, right? So you cannot, level 1 investigation would be diagnostic, yes, ultrasound and Doppler. But otherwise, when you go stepwise, peripheral smear blood test would be the first one. And then you'll move on from there on. Okay. Okay. Then can you continue with that answer to doctor's question on what will be your finding on ultrasound and Doppler in this patient?
So in this patient, we can either or on the basis of portal vein in color Doppler, we can say if it is a portal hypertension or not. If the portal vein is visualized, then we can have portal vein diameter will be increased and the flow, the rate of flow will be decreased. So on the basis of hepatic, then we can also intercut CDS previous. We can also say if it is there are any collaterals or not, and if at all the portal vein is visualized or not. We can also see the status of the splenic vein, and if there
Please
is
tell all the findings that you look for in the portal venous system in a patient with portal hypertension.
now we will see further visualization of the portal vein, diameter of the portal vein, flow
What's the normal
or
diameter?
type
Doctor,
of,
when you speak, you'll have to say the normal diameter is about 9 millimeter to 1 millimeter. Now, my patient, I expect the diameter to be more than 1.2. So then we understand that you've understood the basic concept. Okay. So one is dilatation of the portal vein. Yeah. So then that's number one. Then you say we have a DD of EHPV versus NCPF versus cirrhosis. Can it still be CTPA cirrhosis? Okay. Okay. So now tell So one is, you see, look for the direction. Now tell all the findings you look for EHP view.
Ma'am, we will see for the collaterals.
What collaterals, doctor? What collaterals are you looking for? What is it that you're, where are you looking for the collaterals on ultrasound? Portal cavernoma?
Portal
You're looking for
cavernoma.
bridging, you're looking for bridging collaterals. What are these bridging collaterals? What are they?
Ma'am,
What is this? What is this bridging collaterals? What is it? Cavernoma. What is it? They're all the vena comitatus, which are the communications between the prior to the obstruction versus the post. So they're all bridging collaterals which circumvents the portal fibrosis which is present in these patients. Okay, that is cavernoma. Then what else will happen inside the liver? Inside the liver, you're likely to have what will be the finding in the portal vein, or what will happen to the hepatic artery in these patients?
Non-hepatic artery will be, we will see the peak systolic velocity in the hepatic artery, which can be increased, and resistive index, which is again either normal or decreased in case of EHP view. And we will also look for the appearance of portal in the case in a liver, and we will in the liver we will look for echogenicity and nodularity and any secondary pathology.
Will be the finding in NCPN.
From NCPF, we will have attenuation of the portal vein and liver in the distal part. It will be a winter tree appearance.
I do not know what's a winter tree, madam. I do not know anything about a winter tree. Chennai has no winter, no? We do not know what's a winter tree. So I just want to know what happens when once a portal vein enters the liver. What is that? How do you describe the branches? It's a dichotomous, okay? Dichotomously, it keeps dividing and goes right up to the periphery. So in NCPF, we call it as abrupt truncation. That's the word we use. There's an abrupt truncation after the second degree. So there's a peripheral pruning. So you have 2 degrees, and then after that, second degree onwards, there will be peripheral pruning. Okay, and some of them you can get surface. So if the liver is enlarged, the surface will show oscillation. There'll be surface irregularity because of the retraction of the capsule due to this peripheral pruning. Okay, so that's a finding you'll see in NCPF. So this is how you describe. So can we have some information on this patient, what it was, so then we can move on to the management? At least give us some more information on this.
Ma'am, this is the report of ultrasonography whole abdomen with color Doppler hepatic portal venous system. Ma'am, here we have a liver of 13.1 centimeter and craniocaudal length, which showed altered echo texture with irregular surface, and so ma'am's spleen is of 31 centimeter along the long axis. Splenic veins appear dilated and shows multiple periportal and perisplenic and peripancreatic collaterals. Splenic vein was not visualized, and hepatic artery, the peak systolic velocity was 35 centimeters, and resistive index was 0.71 with a minimal free intraperitoneal collection noted. And impression was chronic liver disease with massive splenomegaly, dilated splenic veins, and multiple periportal, peripancreatic, and collaterals with non-visualization of main portal vein and minimal ascites, likely due to extrahepatic portal vein obstruction.
What was the finding within the liver? The portal venous system within the liver?
They have not commented on it.
That is most important, no? It's such a big, massive spleen. How can you say it's EHP view with the features of cirrhosis? It's a chronic liver disease. You expect that in EHP view? In EHP view, do you expect findings of surface irregularity, altered echo texture, and that is why in your differentials, that's what I said, it would still be CTPA cirrhosis. Okay, only thing the natural history is the patient would by now would have decompensated over these last 14 years. Patient would have 14 or 16 or 17 years should have decompensated. But this is most likely an NCPF that is progressing towards cirrhosis. That's the diagnosis of this patient, and therefore we need details of the vessels. Is a combination. We need details of the portal venous system within the liver to know what we're dealing with. A simple EHPVO would not cause surface altered echo texture and this thing. Her BMI is high. So is there a component of massivity? We do not know. Metabolic dysfunction associated steatotic liver disease. Her BMI, I think, was 25 or 26. She was like slightly on the overweight. Sir, others please take over, sir.
Yeah. Muskan, any other specific investigation you would like to do for her?
Sir, I would like to do upper GI endoscopy, sir.
Yes. So what all you would like to see in the upper GI endoscopy?
So we will see for the site any pathology that can lead to bleeding, and so we will see for varices. Yes, sir.
So how varices looks on upper GI endoscopy?
Sir, esophageal
Esophageal varices.
varices. Sir, it looks like a tortuous vein. Sir, in case of sir, it can be divided into F1, which is a small straight vein, lung, does not protrude after insufflation of in endoscopy. Then it can be of F2 variety, which can present as a tortuous vein, and it can be an F3 variety, which can again be a coil-like and large nodular shaped. We will also see for red signs on endoscopy. Can be cherry red spots, red veil marks, and hemocystic lesions. So, and the
Okay.
colon
Apart from
involvement.
endoscopy, any other tests?
So, as the usual abdominal color CDS previous has suggested a chronic liver disease, I would like to move forward to fibroscanning first.
Okay. So what all you will with the basic principle of fibroscan?
So fibroscan works on the shear pressure and elastic, which measures the elasticity of liver on applying the shear pressure.
Any other investigation?
So the basic investigations, they will like to do the routine
For
blood test.
viral markers, doctor? Would you look for viral
Yes,
markers in
ma'am.
this patient?
Yes,
And what's the
ma'am.
role of viral markers in this patient?
Hepatitis B and hepatitis C can
What
lead
markers
to
would you do in
cancer.
hepatitis B? What markers would you look for in hepatitis B to know whether it's chronic HBV infection?
Ma'am, HBsAg antigen. HBsAg antigen.
What test would you do for chronicity? You'll stop, suppose HBsAg is negative, you'll just stop there. What's the role of anti-HBC total? All these are very important, no? Because this patient will require vaccination. She's a person who's likely to have get repeated transfusions. And she's received some transfusion also. And if both are negative, you have to get her vaccinated for hepatitis B. So you have to look for viral markers. And maybe she's HBsAg positive and the chronic liver disease, she's got an incidental HBV or HCV infection. So what was the viral markers in this patient?
Ma'am, it was, I have not mentioned in here, but it was all negative, ma'am. Ma'am, no viral marker were not positive.
Muskan, how you are going to manage this lady?
Sir, in the management, sir, I would like to move forward with, sir, I can, sir, if the patient presents with a acute bleeding, so we will manage it. If not, then we can manage it. Sir, with
Tell us the grades of varices, no? Then only we know the management. If there are varices or no varices, what was the blood picture? What is the blood picture?
What is the HB? Patient is anemic.
Yes.
You said that clinically. What is the HB?
Yes, yes. So in upper GI endoscopy, there is one column grade 2 and one column grade 1 esophageal varices and endoscopic
Doctor,
peritial
what was
ligation.
the hemoglobin? You said patient has got pallor. That's what the professor is asking. What was he? Tell us the blood picture first.
The hemoglobin was 8.4 gram per deciliter with a decreased total leukocyte count of 3,500 and platelet was also reduced of 65,000. And the viral markers were non-reactive. PTINR INR was 1.2, and the albumin is 3.9, And the general blood picture shows hypochromic, microcytic hypochromic anemia, and the TLC is also reduced, and platelet is also reduced, and the CTP score I would like to give it as a grade A.
So is it hypersplenism?
Yes, sir. Hypersplenism. According to the general blood picture, it is hypersplenism.
So your blood count CBC is going to make any impact on the overall management of the patient?
So, as it is a case of hypersplenism, we will one of the goal of management will be splenectomy, sir.
So that is what Gupta sir asked, that how will you proceed? How will you manage this patient? And for the management of the patient, first and foremost is CBC, right? That you should always mention. So now this is the reports. Would you like to go for how will you manage this patient?
The my goals for management would be first to removal of spleen and control of the variceal bleeding. So I would like to go as it is she is not actively bleeding, so we can go for splenectomy with shunt surgeries.
Surgery in this patient, I'll leave this patient alone. She's finished her family. She's got 2 children. She's asymptomatic. There's only grade 1 varices. Why would you do a shunt in this patient? In EHPVO? For what purpose are we doing shunt?
Ma'am,
And just go back to the endoscopy. When you have grade 1 and 2 varices, would you really push in for an EVL? One
yes,
column.
ma'am.
You could do it just a small, no? They're all small varices. Would you ask for an EVL? And bleed
No,
is also
ma'am.
not massive. Did you give the patient carbidolol? Did you give any of the non-selective beta blockers?
Ma'am,
I
yes,
think the
ma'am.
surgical aspect, as far as I'm concerned, this patient come to me, I'll just leave her alone. Patient is asymptomatic. The bleed was trivial, unrelated to the esophageal varices, and put her on carbidolol, maintain her if she has any dyslipidemia, manage her for that, and leave the patient alone. I will not do any surgical or any other intervention with patient because patient has completed a family. She's had no problem. All this is very important because pregnancy is not that easy in a patient with EHPVO and pancytopenia. History will give you a diagnosis in 80%. That whole history was lacking in this patient because some person during the course of pregnancy, the obstetrician would have said your platelet count is only 20,000, 30,000, you have a liver disease, you have a difficult problem, we have problems in your obstetric management, there's likely to be a miscarriage. All this has to be discussed in this patient. These are my comments as far as the management is concerned. Okay.
Yeah, agreed, ma'am. Muskan, was this EVL done as a prophylactic measure?
So it was done as a prophylactic measure, so
Yeah,
primary
so even
prophylactic.
that was not indicated, as madam is rightly saying,
Yes.
right?
You can
Because
always
patient
give
has only
medical
2
management.
episodes of, yeah. And shunt as of now is not at all required in this lady, right? As
Yes.
per your description, whatever history you have told and whatever examination findings you have given to us. So right now there is no hurry to go for a surgical management for this particular patient.
Yes.
So
If
just
this
coming to
patient
the
presents
shunts,
with
what type of shunts you know for portal hypertension? You know selective shunts, you know non-selective shunts.
Yes, sir.
So what are selective shunts?
So the selections are distal splenorenal shunt, that is the Wharton shunt. It is Inakuchi shunt, that is the left gastric venous and cable shunt. And so it is a Sarpes shunt, that is a small diameter photocable shunt. And in the non-selective shunts, we can have side-to-side splenorenal shunt, that is the shunt. And we can have proximal linorenal shunt, that is the Linton shunt. And we can have mesocable shunt, Drapnas shunt. And TIPS is also a non-selective portal, non-selective shunt. So. And so we can have ECK fistula. That is a
Okay, Dr.
enterocyte
Kirit, you
photo.
were asking some question.
What are the various
Doctor.
type of Muskan? Can you hear me?
Yes, sir.
What are the various types of mesoconversion?
So mesocaval shunt, sir, side to side, the, that is the Drapna shunt.
Side to side is the
And
Draper
sir,
shunt.
it is
You cannot do a direct shunt in between, but you can do any end to side shunt.
end to side, so ECK
Mesoconversion?
fistula, sir, photocaval shunt.
No, no. I'm asking about the mesocaval.
So inferior mesenteric vein and renal vein,
No, you
mesorenal
can.
shunt.
No, you can sometimes cut the inferior vena cava at the inferior end and rotate it to the superior mesenteric vein. Okay. So if you are not able to do a Drapna shunt, this is another direct shunt which is there between the lower end of the inferior vena cava to the side of the superior mesenteric vein. What is the child's grade in your patient?
So it is a child, so A grade A.
Sorry, how much?
Grade A, sir.
How much is the score?
So it is 6.
Six. Okay. And what is the MERS grade?
So MELDs I have not calculated, sir.
No, Varlan.
Okay. Now, what are the direct surgery for the portal hypertension?
So devascularization surgery, sir.
Do you know any name of the devascularization procedure?
Yes, sir. So Tanner operation. It can Hasab operation. It is the Seguira procedure. So
Yes.
there are some modifications as well. So Milne Walker, Johnston,
Yes.
and sir, an Indian modification, sir, Shahi's modification.
Okay. What is size modification?
So it is a modification of Tanner's operation, wherein the anterior, only the anterior gastric resection is done, and the posterior wall is plicated, and there is devascularization of the external devascularization of esophagus and cardia of the stomach. So,
No, you underrun the posterior wall. Okay, after opening the anterior wall, you underrun the posterior wall, and then you suture the anterior wall. Okay, so that is the size modification. And then there is further modification is there. You know, Sada Shivam modification, again Indian origin.
but I don't.
Okay,
Sir,
Sada
there is
Shivam where you do
another
not cut
Mathur modification also.
Yeah, Mathur modification.
I'm co-author in that. I'm hearing everything very carefully.
There are many Indian surgeons which are involved in that. Yeah.
Sir, I have some basic questions for this lady. She's answered very well. I'm very happy about it. In spite of being really grounded, what are the causes of coffee ground vomit without splenomegaly?
So without splenomegaly, so it can be it can be due to peptic ulcer disease. It can be due to erosive gastritis.
What
It
is
can
coffee
be due
ground?
to
What is coffee ground vomit according to you?
so coffee ground vomitus is due to when the bleeding is in the upper GI. So the blood changes into a hematine due to the
So what should be
acidic
the speed
acidic.
of bleed? What should be the speed of bleed in a coffee ground
So
vomit?
it would be slow, and it should minimum of 30 minutes.
Never
Stay
answer
live
more
of
than what is required. Just say slow bleed and keep
Okay.
quiet. Because then I will ask you what is medium bleed, what is rapid bleed. So in examination, be very, very clear as to how you are going to answer these questions. According to me, these clinics are to train all of you all for that. What are the common causes of slow bleed in the upper GI tract? Forget portal hypertension right now.
Slow bleed, ulcer, ulcer, it can be due to peptic ulcer disease, or it can be malignancy as well. And then it can be due to
You're not
erosive
thinking of
gastritis.
erosions at all, right?
Erosive gastritis.
Which erosive gastritis, gastric ulcer disease, or peptic ulcer disease and malignancy, which of these will you give priority in your diagnosis without splenomegaly?
So I would like to keep the
Quickest
erosive
answer is I
gastritis.
don't know. My next question is, what are normal splenic dimensions? Normal splenic dimensions. Length, breadth, width.
The length is 13 centimeter, width is 7 centimeter, breadth is 3 centimeter.
What is normal weight of the spleen?
So 200, 200, 250, 200.
Don't blink your eyes because I'm seeing you. Can you tell me classifications of splenomegaly on a CT scan? Because we have been talking about massive splenomegaly, moderate splenomegaly. I just want you to know.
So massive splenomegaly is when the size is
No,
20
I have
centimeters.
asked you classification of splenomegaly on a CT scan.
So on the CT volume, sir, we can say it is a massive splenomegaly if it is more than one.
I'll give
I
you
don't
one more question. There is splenomegaly on weight and splenomegaly on a CT scan. Which of these two would you prefer? To know as a surgeon that I'm going in on a splenomegaly.
Sir, I don't.
Good. Very nice. So all this, once you prepare for a case on portal hypertension, you got to be ready with all these questions and answers. Okay, that's my take. Basics are more important rather than treatment of portal hypertension, which is supposed to be done by liver people. Thank you so much, the organizers. That's my end. Thank you.
I was just asking, what are the causes or indications in which you will go for shunt surgery? One is variceal
Sir,
bleed. This patient is not having variceal bleed. And what are the other indications for shunt surgery?
intractable ascites, the refractory ascites, uh,
This patient already have a huge splenomegaly, right, with hypersplenism. That is one of the indication.
yes.
Then what is if this patient is having jaundice? How will you manage that? And what are the indications? What will happen?
Sir, jaundice, sir, it is more, sir, it is more in favor of cirrhosis, cirrhotic liver disease. So I would like to manage it according to the cirrhotic liver disease.
Earlier, madam had discussed, Dr. Gupta sir had also discussed, that is portal biliopathy.
Yes, sir. So portal biliopathy will be managed. So we will go for an ERCP. So ERCP stenting can be done.
I think she has answered well. Madam, you can please give your final comments. Madam, you are mute. Madam, you are mute.
So summarizing, I would like to say, yeah, you did a good job, getting all the questions and bombardment from all the examiners around you. But I think you did quite a good job. Only thing what I would say is, I would spend a little more time. Once I actually, what I would do is go straight for the examination, found a big spleen, and then I just say how long you've had it. And once she's had it, then I just ask, who were you during all these years? And then describe the bleed to a larger extent. And then just give us, like it's not like Sherlock Holmes, where we're trying to find out what it is. We want to manage the patient. Patient comes to us more for management rather than for basic diagnosis, okay? Patient would have come to you with a diagnosis of a portal hypertension, and for us, it's a management. And this is most important, patient chronic liver disease, that infertility rates are very high. Menstrual cycles are often irregular. These are all the features of chronicity. And invariably, most of them will have abortions, and seldom would they go through all this, and that with the large spleen, almost the uterus moving up and the spleen crossing. So I think that's important. And as most of us discussed, this case, if it comes to the bedside clinic, questions will be asked only on splenomegaly. In other words, you must know a little bit more about general medicine. Okay. And then portal hypertension is because you know what the case is, you were skewed towards one diagnosis. Had you not known what the case is, you would have had a wide differentials. At least I did not see the PowerPoint, so I did not know what the case was. So therefore, I was able to discuss more than beyond what you thought, because you already knew what the case was. But the discussion will hover around causes of splenomegaly. In splenomegaly, when can you get portal hypertension, and vice versa. And then know the differences between once you made a diagnosis, EHP or NCPF, you must read all the papers from northeast parts of the country, Calcutta papers by Dr. Mazumdar. He's done a lot of work on NCPF. There are huge papers on the role of arsenicosis. Then you must know what are the other causes of NCPF, role of liver biopsy. That's very important in this patient. And they'll ask you the differences, which is liver biopsy at all. So what we tell the surgeons is, if they are going in, take a biopsy, core biopsy. We don't ask for a wedge biopsy or a percutaneous biopsy because it will not be informative. So we always ask for a core biopsy. And a little bit about endoscopy, because surgeons are doing endoscopy nowadays. So therefore, you need to know more about endoscopy. You're given the case, you're the surgeon, patient comes to you. Would you do an endoscopy? Would you do banding? They will ask you, because you're the surgeon who are doing now, you all are doing endoscopy. So they'll ask you, what are the bands? How do you deploy the bands? How do you arrange further this thing? All these questions will be asked. And what's the role? There's no role for any of the non-selective beta blockers in patients who have got EHPVO, because it's a low resistive system. It's only in NCPF and cirrhosis that we give. Otherwise, there's no role. Even if the varices are grade 3, grade 4, it's a low resistive system. There's no role for any of the beta blockers. Okay, these are my comments. But you've done a good job. All the best and best wishes. I'm sure you'll do well.
Thank you, ma'am.
Thank you, ma'am. Dr. Seema, ma'am, would you like to come in at this point? Professor Seema, ma'am.
Good evening, sir.
Good evening, ma'am. Welcome.
Yeah, Dr. Muskan faced all the questions valiantly, but yes, Jayanti madam brought out a valid point that during pregnancy, if there was massive splenomegaly, how it would have missed. So I think that should have been taken up in the history, and maybe the patient did not give proper history, and when did she have the children? She came at age of 36 years, so maybe it was 10 to 12 years back. So yes, that was missed by the candidate, but I think otherwise she did well and did a good job. So.
Okay. Any other faculty would like to give in any comments? Muskan, do you have any doubts to be clarified with the senior faculty here?
Yes, sir. I have.
Yeah, you can ask the question. Faculty can definitely comment.
As in this case, sir, the patient had features of hypersplenism. So should we go for splenectomy? And if we are going for splenectomy, then we can just leave the patient with splenectomy, or we should do any additional procedures as well. So I was not sure about how to proceed in this patient as.
The answer is very simple. If the patient is symptomatic with a low platelet count, you operate. Asymptomatic, leave them alone. So that's it. Because they're worried about the spleen. And mind you, she's gone through the pregnancy. Yeah? So now her family life is completed. So what the spleen is not going to come in any way, except that no one should kick on her abdomen, and cause rupture of the spleen. Otherwise, she's safe.
Thank you.
Any other doubts, Dr. Muskan?
No, sir.
Okay, thank you very much. Madam, the next case is a carcinoma gallbladder. You are welcome to be with us unless you are pressed of time,
Thank you.
ma'am. So,
Thank you.
Jayanti, ma'am, you
I'll
inclusive.
stay connected, sir. I'll stay connected.
Thank you, ma'am. Thank you. And thank you, Dr. Muskan, for taking all the time. But I seriously believe you spend little more time on the history part of it, either with the parents or with the husbands. Many times they maybe have been informed. The patient may themselves may not be informed of considering the gravity of the situation. The volume of bleed has to be definitely taken into consideration because in one slide you mentioned 1 unit of transfusion. Apart from that, spend more time on asking about the how many transfusions were given. That gives a very broad thing. And was there something like an emergency admissions? Indirect questions. Many times, if you have asked them and perused the records, it would have been more appropriate for this presentation. That gives a clue. The other thing is, if the mom of the girl is there, I'll be happy to look into umbilical sepsis. How many days it took for the umbilicus to fall down onwards? Intranatal or perinatal sepsis on the mom side. These are all additional things we'll be very, very interested in knowing about it. Whether the child had extended, like for instance, patients kept on ventilators for a long time, postnatally, a premature child or something, their patient on ventilator, whether the patient had exchanged transfusion in the immediate postnatal period. So many subsidiary questions. You may not get a real answer, but still if the child is kept in the post delivery period, extended in the ICU, or repeated hospitalizations in the early natal period, these things all give a clue, right? And certainly any obstetrician doing an ultrasound or a perinatal antenatal checkups definitely would have picked up these things. So you gently probe them. Was something else told? Some other safety precautions would have told. Many times these girls get married, get pregnant, and then the first antenatal checked up, the obstetrician picks up. Definitely they would have discussed in the team. They would have explained to the family such a risk is there. Unless she is a totally unbooked mom, these things can easily be probed from the mother and asked whether they took a proper booking or not. These things all matter, at least at this point of time. Make it a timeline and give it a notebook. In fact, Jayanti ma'am at this age writes a full notebook of information so that if she, after 20-30 years, if she goes somewhere, she has a way of writing all the liver function tests, 20, 30, 40 liver function tests on a sequence. So it becomes a breeze to understand how the liver is progressively improving, remaining static, or getting decompensated. So documentation per se, as much as possible, probe the family. The previous treating doctors would have certainly given some records, ask them to get hold of it. If not, at least from now on, you please give a proper note written document. Generally, notebooks are not missed. That's what works as well in these type of long patients. Please write in a notebook and give, rather than giving a 1 page or 2 page printed summary, even though it has all the information. Some more people don't lose the notebooks. That's what is our experience in our long-term patients. Keep track of it. Give a very good follow-up advice to these patients because they have to be on follow-up at least once in 6 months. They have to have a liver functions are to be assessed by a proper clinical team, and then evaluation by way of endoscopy scans have to be a lifelong affair. If necessary, I think you have a fibroscan in your department that has to be on a sequential basis. Based on the values which are rapidly going up, sometimes you may require frequent fibroscans. And madam has told about the biopsy concepts also. So it has to be very carefully monitored because the more you leave the liver to go to more denser cirrhosis, the longevity of the patient comes down. But at this point, India has a fabulous transplant facilities also. So keep the options open. Don't exercise all the options at one go. But this is certainly a patient who needs a closer monitoring by the team.
Dr. Kanakavel, just one comment.
Yes,
Please read about the prothrombotic state, okay? We didn't discuss that. So please read all the tests for prothrombotic state and whether the patient will require anticoagulants or it's a long-standing case and therefore we ignore it. In your patient, was this patient admitted under you or the patient was referred from the liver department or some other department for a splenectomy? Can you just answer that final question?
Ma'am, she was referred from gastroenterology. Ma'am, she presented there with that hematemesis complaint.
No. Why
So
was she referred to the surgeons?
So, because she was not actually, ma'am, when she came to us, she said, "I don't have any problem with the lump. I'm all right with it.
Yeah,
I just have the
exactly.
problem
That's
with
what I
the
said. That's
bleed."
exactly what I said. I have no problem. That's what I said. Just leave her alone. But was she referred for splenectomy?
No, ma'am. They say, for the workup and for the management, they have referred to us. But yeah, so, ma'am, they also mentioned that splenectomy is necessary because of the features of hypersplenism.
No, that's where, no, if the platelet, see, platelet count even of 10,000 in a post-transplant scenario, patient, the function is retained. Even the lowest, no, so long as the function is retained, even though the count, we don't do anything, even the count comes to 10,000. The function of the platelet is retained. So better not to meddle. And prothrombotic work are very important. Suppose she was APLA positive, she would have had a bad obstetric history. All these, that's why the history is most important. Okay, thank you.
Thank
Thank
you.
you.
And
Thank you.
the ACG has recently published guidelines on management of anticoagulants in these type of cirrhotic patients. I wish your attention. It's an open access guideline. Please go through that. I think it was in year 2024 or late 25. Please go through the management of anticoagulants in cirrhotic patients or in vasculopathy or biliopathy individuals. So with that word, I think I've taken little longer time on this case because not a very common occurrences. And with the permission of the faculty, we move on to the next case discussion. Dr. Ayush, you are with us?
Yes, sir.
Good luck to you, Dr. Ayush, and faculty here. Please take over. Ayush, please introduce yourself, your unit chief, head of the department, and start your presentation. Madam and sirs, please take over. Thank you very much.
Good morning, sir and faculty. I am Dr. Ayush, third year postgraduate from Department of Surgery, MSTCK. My head of department is Dr. Somprakash Basu, Professor, Department of General Surgery, and monitor is Professor Amit Gupta, Department of Surgery, in charge of HPV unit and in charge of surgical onco, MSTCK. Can I start, sir? Can I proceed, sir?
Certainly,
Yeah,
please
please,
go
sir.
ahead. All of them
Yeah,
are
please.
listening. They are with us in quiet mode, but they will ask questions or comments at their respective time. Please go ahead.
A lady, Miss X, aged 59 years, resident of Dehradun, Uttarakhand. She is homemaker, illiterate, and belong to low socioeconomic status. She presented to our OPD with complaint of pain in abdomen, around right upper abdomen for past 2 months. History of present illness. Patient was apparently asymptomatic 2 months back when she developed pain in abdomen, around right upper abdomen, insidious in onset, progressive in nature, which was leading to back, which was continuous, dull aching, which increased on severity after food intake and relieved after oral medication, which was not associated with vomiting, fever, and abdominal distension. He also has a history of loss of appetite for past 1.5 months and unintentional, undocumented weight loss in last 1 month, which was by loosening of clothes. There is no history of fever, vomiting, yellowish discoloration of eyes, epimesis, passage of black tarnished bleeding PR, no history of altered bowel habit, no history of malaise, generalized weakness, joint pain, no history of hemoptysis, cough, headache, seizure, back pain, no history of abdominal distension. Menstrual history, she attained menopause 10 years back. She is married, had 3 children, all normal vaginal delivery. She has history of pulmonary tuberculosis 3 years back, for which she took tuberculosis drug for 9 months. And she has no history of asthma, hypothyroidism, ischemic heart disease, diabetes, or hypertension. No history of blood transfusion, no history of previous hospitalization, no history of any chronic drug intake, no history of any abdominal surgery in the past, no history of any allergy. Personal history, sleepy disturbed due to abdominal pain. She consumes mixed diet. There is no history of addiction. She has normal bowel and bladder habit. No history of similar disease in family. No history of any malignancy related death in the family. Summarizing the case, she is a 59-year-old female presented with right upper quadrant pain for past 2 months with history of loss of appetite and loss of weight.
Yeah, can you just go to some of your previous slides where you asked for no histories and all that? Go back to your history, doctor.
Oh, sorry.
You're going forward. Can we go back to the history?
Yes, ma'am.
Yeah, just come. Yeah, just move. Next slide. Just keep moving. Yeah. Yeah. No, just wait. No. Can you give us what are the? Just go back to the previous slide. Yeah, this one. Increase in severity after food intake and relieved after oral medication, not associated with vomiting. So, what are the conditions when you can have a pain in the right hypochondrium, which increases after food intake?
Ma'am, C has increased after. It can be acute. It can be because of biliary colic. Like after taking food intake or consuming fat meals, they can have pain in abdomen after food
What
intake.
percentage of patients in your day-to-day practice you find that patients with gallbladder disease get a pain after taking food? You see so many cases, no, with pain in the right hypochondrium. So, what are the common causes of pain in the right hypochondrium which increases after food intake?
Yes, ma'am.
What are the common causes?
Pain in right upper quadrant mostly gallbladder disease.
Gallbladder disease. What about the where's the surface marking of the duodenal cap? Where do you think will be the surface marking of the duodenal cap? So what are the common? Just list out the causes of pain after food intake. Just give us common. Just what are the common causes of food-related pain?
Ma'am, after duodenal due to duodenal ulcer, ma'am.
Duodenal ulcer will get aggravated or get relieved with food intake?
Aggravated, ma'am.
Aggravated. Then what happens to the gastric ulcer? What is the classical duodenal ulcer? The moment the patient takes food, acid comes down, so the relief of pain, right? That's a DU. And then, so one is peptic ulcer disease, most likely either a Johnson's classification, pre-pyloric or a duodenal ulcer that will get relieved with pain. Gastric ulcers can get aggravated with pain. Number one. Number two.
And
Can the pain be due to pancreatic artery?
yes, ma'am.
How many hours? When will you get pain? Supposing a suspect is pancreatic pathology, when will you get pain?
You didn't mention after taking food, after how much time patient develops pain. And is there any specific history of taking specific type of food related to pain?
She had pain after taking fatty meals.
Why should they get pain after a fatty meal?
Ma'am, it causes.
When you say fatty meal, every time she takes a fatty meal, doctor, they're just tearing about the history, too much about this fatty meal and all. Gallbladder dyspepsia is more of a myth, You seldom you get a pain due to that. What really happens is if they take a heavy meal, if a patient's got stone disease, that stone gets impacted at the neck, and then you get an acute cholecystitis like picture. But any other patient will never have a pain related to food intake, okay? It's never a food-related pain, although it's described in the text gallbladder dyspepsia. What will be the pancreatic? What will be the description? That's what sir is asking you. Why do you want to know this? Pain after meal, pain 3 hours after meal, and pain occurs 1 to 2 hours after meal. What is important? What will be the presentation of ischemic bowel?
Pain will aggravate on eating.
Pain will aggravate on eating, doctor. How will you diagnose in a given clinical condition? Patient comes to the emergency in the ER and comes.
Yes,
how will you know it's an ischemic bowel pain? That's also food-related pain.
Yes,
what will be the pain type of? What will be the type of pain in pancreatic origin? When will you get pain in pancreatic origin? You said pain radiating to the back.
Yes, ma'am.
So when you say pain radiating to the back, it's in my mind, I'm thinking of pancreatic pathology.
Pain of Cox abdomen.
Simple question of abdominal pain. Describe the pain of pancreatic origin. Describe the pain of ischemic bowel. We've already discussed some extent peptic ulcer disease.
Pain in pancreatic, patient will have pain in the abdomen around chest region. Patient will be saying that his pain relief on bending forward.
Relation to food, I'm asking. Why do they get pain? Why do they get a pain? Why does a pancreatic pathology cause pain after food intake? Why does it cause pain? Why should a pancreatic pathology cause pain after food intake? What happens when you take food? What happens with the enzymes? What happens to the pancreatic enzyme when you take food? All these basics you should be very strong, okay? You should be very clear because see what happens is with most of us, the present days, we are seeing the reports first, then we see the patient, and therefore that's it. But then if you really spend time taking a history and then doing a proper clinical examination, you'll clinch the diagnosis just with the history and examination. Okay, now what are the causes of pain in the right hip? Please read all this: ischemic bowel pain, pancreatic origin pain, acid peptic disease pain, gallbladder pain. Now, what are the causes of pain in the right hypochondrium?
Ma'am, pain in right upper quadrant is polylithiasis, choledocholitis,
Which one? Sorry?
polylithiasis, polycystitis.
Polycystitis will have pain for 2 months.
No, ma'am.
We're asking for a dull, continuous pain in the right hypochondrium. What are the causes? What are the organs? If you take a right upper quadrant by anatomical distribution, what are the organs that are there in the right hypochondrium?
Right
Viscous, hollow viscous, and solid.
Gallbladder, ma'am, stomach, and hepatic flexure of colon.
Good. And then what about the liver?
And liver, ma'am.
Liver is the most important organ, no?
Yes, ma'am.
No. So you have the liver, you have the gallbladder, you have a portion of the stomach, and you have the hepatic flexure.
Of course.
So can there be a second and third part of the duodenum? Second part, descending part of the duodenum?
Yes, ma'am.
Descending part of the duodenum?
Second part of duodenum.
Yeah, descending. That's what is descending. Descending is second part. Yeah, descending is second part. So what are the causes arising from the liver?
Ma'am, if there is any
She's got loss of
liver
weight.
abscess,
She's
ma'am.
got loss of weight, loss of appetite, and she's got a dull pain in the right hypochondrium. What are the causes?
Hepatocellular carcinoma, ma'am. If there is any.
Classify, doctor. Always classify. Always classify. Classify. Without classification, you cannot answer.
Why can't inflammatory or infective cause?
Yeah, infection, inflammation. Give us some causes, no? Of pain in the right hypochondrium arising from the liver, the gallbladder, hepatic flexure, and the duodenum.
Ma'am, in liver, it can be liver abscess. In gallbladder, acute cholecystitis. In stomach, it can be peptic ulcer disease. And
we are talking of the same patient. In the same patient, in this context, what are the possibilities arising from the liver? We are not discussing theory. In this patient, what are the things that cross your mind?
In this patient, ma'am, it can be unknown primary liver mets.
Keep talking, doctor. So just tell what are the possibilities? Loss of weight, loss of appetite, and pain in the right hypochondrial liver.
Ma'am, it can be intrahepatic cholangiocarcinoma.
Why not viral hepatitis?
It can be viral hepatitis.
What are the points sir is asking for viral hepatitis? Can it be viral hepatitis?
It can be viral hepatitis if patient will complain of predominant symptoms like fever. Patient will have malaise and.
But can they get pain in the right hypochondrium?
They can get pain in hepatitis.
Due to what? Why do people with viral hepatitis get pain?
Because of expansion of glycan capsule.
Good. So that you can get pain. So, but that history is important, no? You get that history. Can it be an outflow tract obstruction?
Yes, ma'am.
Hepatic vein outflow tract obstruction.
Yes, ma'am.
What will be the presentation? What will be the presentation of outflow tract hepatic vein?
Sorry, ma'am.
All this you should know because once you get the differentials, you know from the history taking that. So you say it's hepatic flexure. What will be the presentation of hepatic flexure growth?
Ma'am, patient will have complaint of hematemesis. A patient will have complaint of melena, and patient will have complaint of altered bowel habit, ma'am.
What will be the classical presentation of hepatic flexure growth? Intussuscepting mass lesion, no? They're present like intussuscepting mass lesion. That's the presentation. Now, what are the causes from the you kept on harping on gallbladder? So tell what are the causes from the gallbladder that can cause this presentation?
Patient,
The same case, loss of weight, loss of appetite, and gallbladder pathology.
patient will have, ma'am,
Causes,
since
just list out the causes.
gallbladder, ma'am.
Yeah.
Patient will have complaint in pain in right upper quadrant. Patient will
Doctor,
say,
I'm not asking a symptom, I'm asking you what is your differentials from the gallbladder?
gallbladder, ma'am, chronic cholecystitis, ma'am.
Chronic
It can be,
cholecystitis in this patient. What will be the presentation of chronic cholecystitis?
patient will have complaint in pain in right upper quadrant, which will be radiating to
No.
back.
The chronic cholecystitis will never have pain. They'll never come to you. Only the acute cases will come to you. Chronic cholecystitis is a radiological ultrasonographic diagnosis. What are the other causes of gallbladder pain?
Ma'am, mucocele of GBs and gallbladder, ma'am.
That will be a dull ache. What else?
Ma'am, if
Loss
it
of
is
weight, loss of appetite. What are the causes?
carcinoma of gallbladder, ma'am.
Carcinoma gallbladder, number one. Why do they get pain?
Ma'am, because of first, if there is any obstruction because of gallbladder stone, then there will be expansion of gallbladder, which can cause pain. And secondary, if there is because of taking any meal, there is stimulation of polycystin kinase receptor, which can cause contraction of GB, which can cause pain.
What are the other causes of pain? One is distended gallbladder. Number two, it can infiltrate at the porta. No, gallbladder fossa is in the porta of the liver. So it can infiltrate the porta hepatis. And then you can get pain arising from there. There can be distension, then the involvement of the biliary tract. The biliary tract dilatation can cause pain. You can have involvement of the nodes, portal nodes, and that can cause dilatation of the biliary tract. Again, they can get continuous pain. Understand? So all these you must keep in mind. So that go to the next slide. There are too many no histories. Just go back. Next slide. Now here, see, she's not. Why did you ask for hemoptysis, chronic cough, headache, seizures, back pain, and all? You spent so much time asking all these questions in this patient, and why did you ask?
Ma'am, to rule out any distant metastasis, ma'am.
Distant metastasis, you already made a diagnosis, is it? That it is called bladder malignancy. In a given patient in the outpatient clinic, a patient who comes with you, we just ask for fever, you may ask for cough, but you will hit headache, seizures, and all. If it was present, patient will come out with that history. Okay. And how do you get hematemesis and melena in a suspected case of gallbladder malignancy?
Ma'am, if it is involving hepatic flexure of colon, then patient may present with passage of black tarry stool and hematemesis.
Yeah, the cause more common. More common causes of upper GI bleed. More important in this patient is vomiting. Can this patient have vomiting and obstructive symptoms?
Yes, ma'am. She can have vomiting in operation.
Due to what?
Ma'am, due to biliary colic, ma'am.
Oh, doctor, what else can you have obstructive symptoms? How can you get obstructive symptoms? Can you get obstructive symptoms in gallbladder malignancy?
Yes, ma'am. If it is causing any gastric outlet obstruction, ma'am.
Where? At what level?
At D2 level, ma'am.
All this you should answer. Okay, sir, please take over, sir.
Next slide, please. Next slide. Next slide.
Even in this slide, why did you ask for chronic drug intake, previous hospitalization, blood transfusion? Why did you ask for all these questions in this particular patient? In a given patient in the outpatient clinic, will you ask for, did you take repeated blood transfusion in this patient who comes to you with a pain in the right hypochondria? And
Ma'am,
did you
it-
ask for any chronic drug intake? Why did you ask for the chronic drug intake?
Ma'am, if
What
it is,
question, what chronic drug did you ask? See, it is very
ma'am,
simple, you know, never ever think that you're appearing for an exam. Always think you're sitting in an outpatient clinic. You have to do a quick examination. There are 50 patients waiting outside. Quick history taking, quick examination, making a diagnosis. So those are the important no histories, okay? When you say like this in the exam, no history of chronic drug intake, the examiner will stop. And if that person is a good physician also, they'll ask you all questions on this. They will not move forward. Okay, just move on.
okay, ma'am.
Move on. Give your differentials.
Ma'am, my first differential will be carcinoma GB, and my differential diagnosis is intrahepatic cholangiocarcinoma, and my second is hepatocellular carcinoma, and third is unknown primaries of liver mets.
Unknown primary, I say it is gastric tumor, gastric cancer with Mets. Why do you say it's unknown? You've not asked for any history of dysphagia, you've not asked for a history of early satiety, no nausea, vomiting, all those questions are all missing. Those are the important things, no? There may be nodes at the porta causing pain. It's not an unknown primary, but you've not asked for questions. What are the causal secondaries in the liver? Common causes, 3 important causes.
Ma'am, any colonic carcinoma, ma'am.
Three common causes of secondaries in the liver.
Colonic carcinoma, and another is
Gastric cancer,
rectum.
pancreatic cancer, colonic cancer, and then you have the NETs. So these are all the secondary causes. Most of the times you'll be able to pick up with the primary history. Understand? You cannot say unknown primary. We have not even investigated it. Understand? So your differentials, please, in the exam, even if you know it's a case of gallbladder cancer, please don't give it as a first differential. You'll say, I'll consider differential diagnosis of a space-occupying lesion in the right hypochondrium. That's your first differential. And then you say the possibilities are arising either from the liver or arising from the gallbladder. Or there are nodes at the porta with the dilatation of the intrahepatic biliary system. My differentials from the liver source are this. Gallbladder must stay right at the end. And in the primary could be stomach, colon, although the history is not forthcoming, and the patient could be having secondaries at the porta. And the third possibility is primary gallbladder malignancy. So I think then they'll ask you questions on the mechanisms. Okay? Okay. So we can continue, sir.
So how will you manage this case?
Either examination. It's not
Oh, sorry.
complete. Examination.
Yeah. Please. It is the history. Okay. Next slide, please. Next slide.
General examination, sir. Patient was examined in well-lit and ventilated room, maintaining privacy in presence of female chaperone. Patient was conscious and oriented to time, place, and person. Patient was averagely built, moderately nourished. Hydration was adequate. Patient weight was 53 kg, height 166, and BMI 19.23. ECOG was 1, and Karmasis performance scale was 90. Vitals febrile to touch. Pulse rate was 86 beats per minute over radial artery. Rhythm was regular and good volume. BP was 109 by 80 millimeter of mercury in supine position over right arm. Respiratory rate was 20 breaths per minute, and saturation she was maintaining 98% on room air. General physical examination: no pallor, icterus, clubbing, cyanosis, pedal edema, general lymph nodopathy. Left supraclavicular lymph node was not palpable. Neck vein not visible. No swelling in the neck. No sign of chronic liver disease. Systemic examination: CNS no focal neurological deficit. Respiratory bilateral air entry was present. No vesicular sound and no added sound. CBS S1 S2 heard, no murmur heard. Musculoskeletal, no skeletal deformity, no gait abnormality. Per abdominal examination, inspection in supine position. Diffuse bulge was seen over right upper quadrant. Umbilicus is central and inverted. All quadrants were moving proportionate with respiration. There is no dilated vein, sinus, or scar marks. No visible peristalsis pulsation. No visible cup impulse were present. No inspection of back and spine. No scar or sinus over back or in deformity. External appear normal and no scratch mark. palpation. On superficial palpation, there is no local rise in temperature or tenderness. Ovoid lump of approximately 4.3 centimeter in the right upper quadrant, just below the right costal margin, lateral to lateral border of right rectus abdominis. All margin are defined except for superior margin, smooth surface, hard in consistency. Moves on respiration, side to side mobility is restricted. Liver is firm, non-tender, palpable 3 centimeter below the right costal margin in mid-clavicle line. Spleen is not palpable, no other lump palpable over the abdomen.
Why did you look for the spleen?
Um,
Why did you spend time looking for a spleen in this patient?
Ma'am, if
It's important, but why did you look for it? Why did you spend so much time looking for a spleen and then say spleen was not palpable? Suppose it was palpable and you've not done your right, you've not put the patient on middle, you've not done a Middleton test, you've not done all the other tests for a splenomegaly, trop space dullness and all, and you missed it. Why is it important?
ma'am, if there is any liver disease and patient is having any portal cirrhosis, portal.
Same patient, in this particular patient, why is it important? Look for the spleen. You can have portal vein thrombosis, no? What's
Yes,
the
ma'am.
relationship of the gallbladder to the portal vein and hepatic artery and the bile duct? Can you just tell us the marking? Portal vein, bile duct, and hepatic artery? And what's the
Portal,
relationship of the gallbladder in relation to all these three?
portal vein is just
You're a surgeon, no? You need to know this anatomy, basic anatomy of then only you'll understand why gallbladder involvement of the portal vein is important.
it can cause, ma'am, compression on portal vein, so it can cause portal vein.
It can cause compression. Can it cause portal vein thrombosis? Sir, can you please take over this? This discussion may be important from surgeon's point of view. One of you can please take over.
Ayush, actually, any malignancy may predispose for portal vein thrombosis, right? So
Yes, sir.
there are certain disorders in the coagulation, and even gallbladder carcinoma per se may lead to portal vein thrombosis, may lead to secondary portal hypertension. This is what actually madam wants to ask from you, right? Or even splenic vein thrombosis. So in that case, you will see there might be a splenomegaly,
Yes, sir.
right? This is what madam you wanted to ask from you.
Yeah. Portal vein, you have to examine the spleen because you can get, we still know not so. No, now you've known it's a gallbladder. But the patient can have portal, it almost becomes a stage 4 disease, no? Then you didn't answer that question, doctor. What is the portal vein and hepatic artery and bile duct anatomy in the fancy formulae?
Um,
What is Callet's triangle?
Callis triangle, ma'am, superiorly it is a medially it is CVD and inferiorly it is hepatic artery and superiorly liver, ma'am.
Superior hepatic artery. Then where does hepatic artery? What's the importance of Callet's triangle?
Ma'am, if
They're
there is
they're
any
deviating. Okay, I think we'll take up for discussion. Just move on. Finish off. Let's go to the next one. Now, can this mass that you felt, can it be exophytic mass arising from the liver? That's my only question on this case. Just go back to your previous examination. This particular description that you're given, can it be an exophytic lump arising from the liver?
yes, ma'am, it can be, but it is since it is
I say it's an exophytic mass. It's a hard mass arising from the liver. Just HCC. No intrinsic mobility. It will move with respiration. The shape ovoid is just a misnomer, and it is a mass that is arising. This question is often asked. No, it may be just a hepatocellular
yes, ma'am, it can be, but
your differentials. Are you 100% sure you're dealing with a gallbladder, or is it possible that you're dealing with a HCC?
it is one of my differential, ma'am, but it can be it is since it is a void lump and it is
Void and all is what you feel, doctor, because you know the case. But otherwise, gallbladder mass may not have that gallbladder shape. Once it becomes malignant, it becomes like a mass. It just becomes like a firm mass with a well-defined margins. That's all. And if you have an exophytic growth, a hanger from the liver, you will not be able to differentiate. So your DD should maintain as HCC versus. But the whole thing is, but the thing is, the gallbladder cancer is more common in North India and all that history. Based on that, you consider the possibility of, okay, just move on. So what's your diagnosis? Now quickly tell what's your final diagnosis and how to investigate.
The final diagnosis is carcinoma gallbladder, ma'am. And
Doctor, in medicine, there's nothing definite about anything, okay? You have, give us your differential. Never ever give just one diagnosis. What are your differentials?
And my differential are hepatocellular carcinoma, intrahepatic cholangiocarcinoma, and
intrahepatic cholangiocarcinoma will present like this, sir. What will be the presentation of intrahepatic cholangiocarcinoma?
Ma'am, it has
How often will you get a mass? How often will you find a mass moving with respiration in intrahepatic cholangiocarcinoma? You understand? So when you're discussing, you're talking of a lump. So HCC is one possibility. It can be a huge fibroadenoma. It can be one of those tumors. Adenomas, they're all exophytic tumors. Understand? Intrahepatic cholangiocarcinoma is intrahepatic. You'll not get a mass arising. You'll find a mass, but you may not find it as a hanger from the liver, as a DD for a gallbladder cancer. So one DD will be GB cancer. Number 2 would be this
hepatocellular carcinoma.
Hepatocellular carcinoma and other tumors, but it's hard. And therefore, it's likely to be more neoplasm malignancy rather than a benign pathology. So can we move on? Can we move on to the
Just one question.
Please, sir.
Just
please.
one question. In your palpation, the previous slide, please. No. Palpation. On this. So you have written there is a 4 by 3 centimeter mass. So what is the relation with the liver?
So it is continuous with the
mass.
The mass was the percussion on percussion. The mass was continuous with the liver dullness.
That you are not mentioned.
So I mentioned in percussion, sir.
In palpation, it is very important whether the mass is in continuation with the liver or is it arising from the liver or it is different from the liver. That you have to mention.
Okay, sir.
What is umbilication?
I don't know, sir.
It is seen in the liver secondaries, right?
Necrosis, central necrosis.
Central necrosis. So whether this is primary liver, secondary liver, or a gallbladder, madam has already told you very nicely. So I think, madam, we can proceed further with the investigations.
Please, yeah. So what investigations one? So examination over, some differentials. So what? Let us see that you want to make a definite diagnosis. What's one investigation you will do to make one diagnosis?
Ma'am, ultrasound, ma'am. Ultrasound whole abdomen.
Answer the whole question, doctor. Ultrasound, that's all you'll do, only ultrasound. What else will you do? Along with a Doppler. Always ultrasound is combined with a Doppler. Ultrasound is always combined with a Doppler. So that in one go, you make a complete diagnosis about the invasiveness of the pathology. So now tell us, what are the findings you look for in this patient? We do not know what's the case. So what are the things that you look for?
Ma'am, we look for any liver as well, and we look for if there is any free fluid.
When you place the probe, no? When you place the probe, what's the first thing that you look for in this patient?
Ma'am, any lesion over the liver and.
Doctor, first will be IHBR, no? You will first, moment you place the probe, your first thing is you're looking for IHBR dilatation.
Yes, ma'am.
And then you'll trace the IHBR. That's the first thing. Liver, of course, you'll be seeing. You'll look for any SOL, you look at the echo texture, you look for surface irregularity, and the focus will be on you're already suspecting a case of gallbladder malignancy. So you're looking for IHBR. You'll follow it up at the porta. You'll follow up for the CHD and come down. And then what are the things you look for then in the gallbladder?
Ma'am,
what do you expect in this patient?
Gallbladder thickness, ma'am. If there is any asymmetrical wall thickness.
Doctor, be very definite. No, you're going to be a consultant. So just tell 1, 2, 3, 4. These are the things I look for. I look for the gallbladder mass. I expect calcification, which will be porcelain calcification, which will be irregular, which will be interrupted. I explain, 80% of the patients can have gallstones. So I look for I look for gallstones in these patients. I look for the size of the gallstone. She's a female. One size stone or 1.5 centimeters means something totally different from multiple stones. I'll also see whether there's an effect of this gallbladder mass, whether it's a neck or involving the body, and see whether it's infiltrating on the undersurface of the gallbladder and whether it's involving the CBD and pressing like a Mirizi syndrome. All this you'll have to mention.
Yes, ma'am.
Supposing this patient did not have, when is a gallbladder not palpable? When is a gallbladder not palpable in a gallbladder malignancy?
Ma'am, when there is, if there is any chronic, because of chronic cholecystitis, patient, the gallbladder gets
Number one.
fibrosed.
Number two, it is undersurface of the gallbladder, undersurface of the liver. So the gallbladder is on the undersurface of the liver. That's a surface marking in the GB fossa. You'll not get it. One important differential diagnosis you've not discussed. Can it be XGC, xanthogranulomatous cholecystitis? You've not discussed that at all.
Yes,
I say
ma'am.
it's XGC.
It
It's
can
got
be
nothing. It's not
xanthogranulomatous, ma'am.
It can be. Nahi, you tell me now. Can it be XGC?
Yes, ma'am.
It's a
It can
very
be, ma'am.
important DD. How will you differentiate XGC from GB cancer?
Ma'am, clinically it is very hard to differentiate between GBC and
Therefore, it becomes an important differential diagnosis in your clinical examination. So on ultrasound, how will you know it's XGC or it is GB cancer? What are the characteristic features of XGC versus gallbladder cancer?
Gallbladder cancer will have lymphadenopathy, and there will be in
Please
gallbladder
you write you now. We don't have much time. See that you have a table distinguishing XGC from gallbladder cancer. So you look for all these things. So what do you expect in this patient? So what was the finding? Can we have the findings? And then
Yes,
you
ma'am.
trace the CBD, you trace the splenic vein, you'll see the spleen, you'll see the pancreas is normal, you'll see for nodes at the porta. All these things you'll have to mention, okay? We're not suspecting pancreatic malignancy, so therefore we'll not discuss about the other signs that you look for. So can you just tell now? What are the findings?
On ultrasound whole abdomen, ma'am, liver was 17 centimeter enlarged. Multiple hypoechoic to hyperechoic lesion were seen in bilateral liver lobe, largest measuring 10 cross 9 mm in left lobe and 14 cross 10 mm in right lobe. GB was partially distended. A hyperechoic calculus was noted in GB neck. Asymmetrical GB wall thickening in hepatic surface with echogenic mass like infiltration in surrounding liver segment 4B and 5. CBT was not dilated and no free fluid. Impression features suggestive of GB mass lesion with infiltration adjacent liver segment and liver metastasis hepatomegaly.
So what's your take?
Ma'am, it is GB mass
That's what I
infiltrating.
said. So this is the same thing what I said. The fossa, no, it's in the gallbladder fossa involving the 4A and 4B.
Yes, ma'am.
That's a bed. That's the porta hepatis bed. So what is your diagnosis now? Complete diagnosis. Stage. What's the stage of the disease?
Carcinoma stage, ma'am, 3, ma'am.
What 3 is already gone? Metastasis in the liver, no?
Yes, ma'am. Stage 4, ma'am.
It's advanced gallbladder cancer, no? It's advanced
Yes,
gallbladder
ma'am.
malignancy. And there's a background of a stone. That's what I said. See that 1.5 centimeters.
Yes, ma'am.
Okay. So can we ask some questions on this? So what are the risk factors for gallbladder cancer? Do you know of any regional differences in gallbladder cancer across the country?
Excuse me, I didn't hear, ma'am.
Any regional differences in gallbladder cancer across the country?
Ma'am,
Madam is wanting to ask you why there is a geographical variation in the incidence of GBC in India.
it is because of compounds like secretion of mustard oil contamination.
I'm not asking you the causes. I'm asking you, is there a regional difference? Do you know of the epidemiological studies of gallbladder
It
cancer
is more
in the
common
country?
in Gangetic belt, ma'am.
I don't know what's a gangetic belt, doctor. I'm asking you, what are the areas where you have huge amounts of gallbladder cancer and where is it not known or hardly seen? Which portions of the country, parts of the country where you hardly see gallbladder cancer? And why? Have you read Usha Datta's papers? Well, have you read my papers? So, by the way, you understand? So, down south, they're all pigment stones. 90% are pigment stones. Cholesterol gallstones are just about 2%. Whereas in North and Northeast, they're all cholesterol. Most of them are cholesterol or mixed stone. So cholesterol constitutes 60% and 20%, and pigment stone is just 2%. Bile in Northeast and northern parts of the country are all lithogenic. So gallstone, gallbladder cancer is very high. So any patient with gallstone disease in North India, we are justified in doing a cholecystectomy because association of gallbladder stone with cancer is there, but it's not, we don't say that stone causes cancer. We're not saying that. But if you take gallbladder cancer, 80% will have stone disease. Okay.
Yes,
So
ma'am.
you must please read the regional differences. Read Usha Datta's paper. You must know the regional differences in the gall. So down south, if I get a case of obstructive jaundice, gallbladder cancer will never come in my differential. Whereas in North India, if you get a case of obstructive jaundice, number one investigation is gallbladder cancer. Okay, these are my important messages of this case. Sir, please take over, sir.
Just one thing that I wanted to point it out, that you're in inspection, you're not mentioned the left supraclavicular region.
Yes, sir. I have mentioned in general physical examination, sir.
You're mentioned in general physical examination. Okay.
Yes.
Okay, fine. So now what other investigation you're gone for? Now how will you plan the management of this patient? You've got a CT scan.
Yes, sir. I have done CCT thorax plus abdomen, sir. On abdomen, liver was enlarged, size 17.6 centimeter. And there was multiple ill-defined heterogeneously enhancing lesion were noted. Largest measuring 9 cross 8 mm in segment 4A, likely metastasis. Gallbladder was distended, GB primary lesion, ill-defined heterogeneously enhancing mass lesion of size 2.5 cross 3.6 cross 3 centimeter, involving gallbladder fundus and body, associated with asymmetrical enhancing mural thickening, maximum thickness 9.5 mm, extending from fundus, body, neck of gallbladder to involving cystic duct, common hepatic duct, and CBD. Maximum caliber of CHD 4.7 mm. And
So
as a
what is the staging after your CT scan is done? The final staging?
So it is metastatic advanced GB, sir.
How should you treat this patient?
This is the patient. How will you treat? What treatment options you have?
Since it is a metastatic case, ma'am, we will go for biopsy, ma'am. We will go for biopsy from the lesion and chemotherapy, palliative chemotherapy.
Tell details of the treatment, doctor. Tell details of the treatment. What was the bilirubin level? What is the liver function test? Give us some information. What are the tumor markers?
Liver function, ma'am, ALP was elevated 195 and CN99 was 10,000 and CA was 59.2 nanogram per ml, ma'am. Other parameter was within normal limit, ma'am.
So you'll do a tissue biopsy, and what will be the drug of choice for chemotherapy, and what will be the survival benefit? What will be the patient asks you, what's the survival? And patient has got loss of appetite and weight. So how should you manage that? Loss of
patient,
appetite.
Yes, ma'am. We first we'll go for biopsy, and after biopsy, we can plan for gemcitabine-based therapy, ma'am.
Patient is already having loss of appetite. So how will you treat her? How will you feed her? All this you have to know. Patient is there in front. Patient says, I'm not worried about the pain. You give me some pain reliever, but I want to eat. So how will you manage? This patient will go straight to the oncology department. No, the patient they will not come to the surgical side because the surgical option is not there.
Yes, ma'am.
Anyway, this case is not operable. So the questions this case may not come to you except up to the examination. No, they'll ask you up to examination, and then they'll just say, most probably you'll just say that I'll be referring the case to the oncologist who will take charge of it. The patient is inoperable and is not a candidate for surgery. So some of you can ask some questions on surgical aspect of gallbladder cancer, sir, then we can conclude.
So, Ayush, suppose it was a localized disease to the gallbladder and there were no liver metastases, right?
Yes, sir.
So then how will you have managed this lady?
If it was not localized and it was found to be resectable, we can go for a radical cholecystectomy in this patient.
So what do you mean by radical cholecystectomy?
Radical cholecystectomy is en bloc removal of en bloc resection of gallbladder with segmental resection of 4B and 5 of liver segment with hepatoduodenal ligament and you have to cable lymph node sampling.
So with lymphadenectomy along hepatoduodenal ligament, right?
Yes, sir.
Okay. So what are indications of bile duct excision during radical cholecystectomy?
If it is involving CVD, sir, if there direct invasion of CVD, and if the cystic duct margin comes out to be positive during frozen section, and if there is any cystic, if the lesion is in cystic duct which is infiltrating into CVD, sir.
What are the other indications?
If there is any hilar infiltration, sir.
Suppose there is a large nodal burden along the
Along the
cytochondrial chain,
yes, sir. If there is any,
So-
yes, sir.
right?
Yes, sir.
And suppose it is associated with primary sclerosing cholangitis or abnormal pancreaticobiliary duct junction or choledochal cyst. Will you like to excise duct or not?
Yes, sir.
And in many cases of papillary variant of carcinoma gallbladder, also there is an indication of duct excision as there might be a tumor thrombi. If not macroscopic, microscopic tumor thrombi may be there in the bile, right?
Yes, sir.
Okay. Suppose you are doing a sampling from priority group of lymph node level 16B1, right? They come
Yes,
out to be positive on per of frozen section study. So what you will do?
So we'll abandon the procedure because it will be considered metastatic at that time, sir.
Okay. So what is the role of non-anatomical or wedge resection of liver versus anatomical resection?
So it has been found that anatomical and non-anatomical non-anatomical has there is no extensive survival benefit if we do anatomical resection of liver, sir.
So are there any condition where you should go for preferably you should go for an anatomical liver resection during radical cholecystectomy rather than just taking a 2 to 3 centimeter of wedge of liver? What literature has to say on it?
Sir, if there is any
You can tell him the answer, sir.
So when the tumor burden is very large, right? And when there is direct infiltration on CT or ultrasound, you can see they are encroaching onto segment 4B and 5, right? So
yes,
then it becomes an indication to do a formal formal segmental or anatomical resection rather than just doing the non-anatomical resection.
yes, sir.
Okay. So what other surgeries you have seen in CA gallbladder apart from radical cholecystectomy?
Yes, sir. If there is any invasion along the extended radical cholecystectomy.
So
And
you can do a right hepatectomy or you can do an extended right hepatic resection, right?
yes, sir.
What else? But more radical surgery you can actually do in
Hepatico-pancreaticoduodenectomy, sir.
yeah, HPT. So have you ever seen that?
I have not seen it, but yeah, it had been done, yes, sir.
Okay. So what you do in hepatopancreaticoduodenectomy, it's a very morbid procedure.
Yes, sir. We'll do extended hepatectomy with pancreaticoduodenectomy, sir.
Yeah,
Okay.
but tell
What is
anastomosis
the
also, no? You have to
Yes.
tell. You can't just, it cannot just be hanging there, no? Tell the complete procedure. You hepatoduodenectomy, pancreatectomy, and what are the anastomosis that you will do?
We'll do
All that
gastroduodenostomy
you
with
see when you in the exam, just one, like you're a little blunt in your answer, just to tell you, just to improvise on that. So, just tell, yes, I will do this. And along with this, anastomosis, so that the continuum is maintained. So what are the anastomosis that you will do?
we'll do gastrojejunostomy and hepaticojejunostomy and jejunojejunostomy.
Liver, so you're removing hepaticoduodenectomy, you said, now which portion of the liver? So I do not know anything. So you must tell me in such a way that I understand which are the anastomosis you're doing.
We'll do anastomosis with the left hepatic duct with the jejunum and gastrojejunostomy.
And what happens to pancreatic duct?
And we'll anastomosis with pancreaticojejunostomy, ma'am.
So you believe in a roux and Y, or what is it? Or you just put one? Where would you take the loop from, the jejunum? How many centimeters away? At what level will you pick up the jejunal loop?
45 centimeter, 45 to 60 centimeter, ma'am.
From where?
From DJ flexor, ma'am.
Yeah, you have to tell it. No, answer in a proper way. 45 centimeters from where?
From DJ flexor, we will take 45 to 60 centimeter.
45 to 60 is a huge variation, okay? We're talking of 15 centimeters more.
45 centimeter, ma'am.
So supposing you're doing a cholecystectomy for a gallstone disease and suddenly you encounter that actually there's a small growth there. What would you do at laparoscopy?
Ma'am, if there is if it is on post-op and we found out to
not
be
post-op. I'm telling you intra-op.
We'll send for frozen section if there is any if we have in we'll go for we'll try to we'll abandon the process. We'll go for restaging of the disease, ma'am.
Sir, can you just take up that question, sir? That is incidental. You pick up, and then what would you do?
Yeah. What do you mean by incidental gallbladder cancer?
Previously, we have not thought of any GB malignancy, but intraoperatively, we found out to be there is GB growth, and when sending out for frozen section, it came out to be carcinoma, sir.
So what should you do then? One is you cannot just take over this. You have to tell the relatives standing outside, no? Outside, the relatives will be waiting, and you suspected XGC, and then it turns out to be gallbladder malignancy. So what would you do on the table?
Ma'am, we will look for resectability if the lesion is resectable or not, ma'am.
How would you do that? How will you do? You're done. It's a gallstone surgery. You've gone in for a planned cholecystectomy, and suddenly you land up with this finding. So what would you do? Do every patient with gallstone disease require a CT scan for staging?
They can go for PET-CT, ma'am.
PET-CT? No, doctor. This is on the table. I'm telling you. On the table you picked up a frozen section is positive. Sir, can you please, sir, Dr. Parmar and Dr. Amit?
Ayush, actually, what is the Lucknow technique or SGPJ technique proposed by Dr. V.K. Kapoor for such eventualities?
We can go for anticipatory extended cholecystectomies.
So what do you do in that?
Ma'am, we will remove gallbladder with 2 centimeter wedge resection of liver, sir.
What about lymph nodes?
If the GB come out to be negative, then we'll consider for extended cholecystectomy. If it is come out to be positive, then we'll further take out the lymph nodes, sir.
So how many minimum number of lymph nodes you should harvest to call it as an oncosurgically safe radical cholecystectomy?
Minimum 6 lymph nodes, sir.
Okay. So what are the salient differences between the AJCC 7th edition and AJCC 8th edition for gallbladder cancer staging?
Sir, in 7th edition, there was based on location, and on the 8th edition, it is based on number of lymph nodes, sir. On 7th and one, it involved pericortical celiac lymph nodes, and on at addition, there was N1 less than 1 to 3 lymph nodes, sir.
Okay, Dr. Kirit, you want to ask him some question?
Oh, I think we have discussed much, and at PG level, he has answered, I think, very nicely. And I think with the permission of ma'am, ma'am, you can please conclude.
Concluded. Dr. Kanakuvel, you can take over and conclude the session.
Yes, yes, ma'am. Yes, ma'am. Thank you very much. Dr. Ayush, at this point of time, what do you think is the longevity of the patient?
Sir, nearly 6 months, sir, or less than 6 months.
So, considering the newer norms where people believe in patient comfort levels and the patient reported outcomes, like be sensitive to the pain and other things. So, what are the typical progression do you expect in this patient? That is, what is the end point? What is the disease progression and what takes over or heads to the patient towards death?
So mostly patient will go under, if the disease extends, they can go under obstruction, and
okay,
for which we can do palliative maneuver also. And if the disease can involve
okay, I will make life easier for you as an examiner. What I expect from you is, see, palliation have to be to alleviate the symptoms what the patient progresses towards death. Here, number one, first thing is the disease compressing the biliary tract. That is a local effect.
yes,
And the disease, once it breaches the serosa, it becomes very rapidly transperitoneal spread, where it spreads into both peritoneum as well as to the bowel serosa and to the other organs. So technically, the first thing is obstruction to the biliary tree. The second thing is obstruction to the remaining part of the GI tract.
yes, sir.
Third thing is, as the patient disease spreads out of it becomes T4, the cachexia grows up because the tumor volume grows multifold higher than the primary volume. The metastatic load becomes very high. So once the metastatic load becomes very high, the anorectic components, the cachectic components secreted by the tumor load becomes a major thing. So generally speaking, these patients go for sort of a bedriddenness very rapidly.
Yes, sir.
Become cachectic, become metabolic state because nothing gets absorbed. First of all, no appetite. Number two, no bile or no intrahepatic circulation possible. And the bowel gets rapidly accumulated by the tumor cells. If very few publications are coming in, what is the most recent? I won't tell recent, like quite some time it is there. Other consideration, will you any other invasive laparoscopic procedure for a time being delay or extension of the lifespan of this patient? In simple words, can you tell what is the role of PIPAC in this patient? Is there a role at all?
Yes, sir. What, sir? I could not hear you.
Sorry, ma?
What is the role of, sir?
PIPAC,
Hypertension.
P-I-P-A-C.
Sorry, sir, I don't know, sir.
No problem. For the student's sake, PIPAC is a terminally ill patients where you have extensive peritoneal carcinomatosis. In simple words, peritoneal carcinomatosis indices plus of 8. People should go and read about what is peritoneal carcinomatosis index. So in patients who has colorectal cancer, liver cancer per se, or any malignancy, abdominal intraperitoneal malignancy, including if it is a lady, consider even genital malignancies also, in incurable advanced disease where the patient is having reasonable performance status. We don't talk about PS5, we are talking about PS2 and 3. If the patient has performance status, good performance status, it is a single port laparoscopic procedure where you do a intraperitoneal aerosolized chemotherapy. That is called as the PIPAC, right? So it gives an aerosol depending on what is the origin of the cell. Here, the role of monoclonals and other immunotherapy have to be considered. That is the only reason you may require a biopsy where you will understand what are the submolecules you can extend the lifespan. Please understand, extend the lifespan.
Here, the most important things which are considered are the PDL1 and the EGFR and VEGF. Now, SD4 or SD10 are the newer molecules which are being considered. See, please note these things show survival increase by 15 days, 30 days, like that. But the cost of therapy, if you are considering, it runs to 10,000 to 20,000 US dollars per injection. So, for all reasons, for scientific discussion, you should be aware of these therapies. But for practical reasons, in the country like us, where the resources are limited, you should be aware of such therapy existing. But the multidisciplinary board does not accept these therapies for practical regular use for these patients. Number two, if and if you are going to alleviate with PIPAC works well for metastatic gastric cancer, metastatic colorectal cancer, where you have, they have shown even gastric cancer with liver metastasis patient with PCI up of 18. The recent publications have shown a lifespan of up till 1 year. They are showing more than 1 year survival status for gastric cancer. Unfortunately, gallbladder is still not accepted as a regular patient use. Limited center studies have shown very, very meager increase in the lifespan. So PIPAC is not recommended, but PIPAC is an option for increased peritoneal carcinomatosis, especially in patients who has good performance status. Unfortunately, gallbladder cancer patients do not maintain that good performance status even for few months. They become rapidly sick. All right. So most importantly, what happens is they develop rapid tumor thrombosis or portal vein thrombosis immediately, causing sort of a like emergency portal hypertension. So patient becomes pyemic, portal pyemia sets in very rapidly, and hence the gap junctions widen. So patient gets into a systemic sepsis very rapidly. Whereas in colorectal metastasis and other metastasis, patient don't deteriorate this fast. But many times it is a block of the portal hypertension and systemic spread of the gap junction induced septic anaerobic sepsis into the system. These patients become unconscious or become, like what to say, hypoconsciousness. That's what we say in malignancy, where the patient rapidly goes into a phase of sepsis and dies off. All right, these are the things you should have in mind. But then I would recommend you to go back to DeVita and read. Natural course of progression of death will be a common question whenever you are talking about a malignancy. Say in gastric cancer, how a patient dies. In liver cancer, how a patient dies. If you see that timelines, you will be able to understand and you will know what are the potential interventional, endoscopic, radiological intervention, endotherapy, or surgical therapy. And then guide or gauge the situation. And many times CAGP is the very still as of now, one of the very highly mortal diseases, CAGP. So your question will be palliation in CAGP. If there is a question, you should have a clear path to answer the question. Give valid 10 points. I will alleviate the jaundice. I will try to increase the longevity of this patient. Only these two things. And you also mentioned what all things, the role of supportive therapy. There'll be one big question asked, how do you maintain nutrition in these patients? Many times you end up placing a nasojejunal tube. That is all you can do, because to an extent, at least elemental nutrition can go in. All right.
Yes.
The next question is, what is the quality of life? Very poor quality of life. So end of life support therapies have to be arranged for these patients. Hospices have to be arranged for these patients. And a frank discussion with the family members have to be informed in, like, you take them along with when you're doing your multidisciplinary discussion. That's the best place to do. They can vent their feelings. They can ask more difficult questions in the presence of cross-specialty experts. And please document everything in clearly. And then, as Madam said, it is prudent we hand over to the palliative group of oncologists where what possible they can attempt. All right. So this will be an overall cover. But in general, metastatic gallbladder cancer, what are the treatment options? It will be a short note question for you, number one. And then progression of the events and newer therapies have to be considered.
as a short note. So SD10, SD4, EGFR, VEGF, PDL1 therapies have to be considered as the armamentarium, as a rescue. It is not a primary therapy. As a rescue, some form of treatment response you hold. Certainly, you don't aim for any cure in this patient. If you can, I would say, reduce the rapidity of the tumor load or reduce the speed of tumor doubling time to 10% or 20%, you are winning in this type of metastatic cancers. All right.
Yes, sir.
So these are the word of things. But again, go back to read DeVita. DeVita gives a very clear timeline how this tumor progresses. The other thing is Blumgart's is the next textbook to go back. I'm sure your department has a copy of it. So go for the treatment, end stage care for CA gallbladder. There is a full chapter on it. Please go and update yourself about the recent updates of the therapy. The last thing I would recommend is whenever you're coming for a presentation, please read the most updated NCCN version. NCCN version gives, it does not read only about the surgery, it gives about endotherapy, interventional therapies, image-guided intervention, as well as the pure form of palliation. So gallbladder was updated as late as this early January 2026 NCCN guideline. I wish you go through that. Whenever you're coming for the presentation, please upgrade yourself knowledge on NCCN and then come and speak with the NCCN basis. You have a focus. That is a one-stop access for all the information. All right?
Also, Dr. Kanakave, there's an ICMR consensus. Okay, there's an
Yes.
ICMR Indian consensus. So
Practice
please read
parameter.
that.
Yes.
Yeah, Indian consensus, you should know ICMR consensus on management of gallbladder cancer.
True,
Okay,
ma'am.
There
thank
is a IHPBA consensus, madam. Actually, IHPBA and Asia Pacific HPBA
Yeah.
consensus guidelines.
That's, yeah. There's one other I've read, ICMR consensus by from Just Look Hospital. I think one of the surgeons has written it. Thank
Yeah.
you, Dr. Kanakave. Can we conclude?
Thank you, ma'am.
Thank you.
Any other questions, ma'am? Can we call a close?
Yeah, please.
Ayush,
Yes.
Amit sir and Krit sir.
Yes, sir.
Yes,
We
yes.
can close.
We can
Thank you
close.
very much. Thank you very much for all of
Thank
you.
Yeah.
And
Thank
Good
Muskan,
night,
thank you
sir.
very much for
Good
staying.
night, all.
Rajiv sir, thank you very much. Good night, sir. Good night, everyone. Thank you, madam.
Good night.
Good night,
Good night.
sir.
Thank you.
Good night,
Thank you.
madam.
Thank you. Thank you.